If you feel you're too deep, you can adjust. So here you can see the blue tracts or the blue lymphatics very well. And then after I've injected my methylene blue, I do a 3 to 5 minute breast massage. So the massage is to help the methylene blue travel to the axilla area. Um, I apologize for the video. It seems to be very vigorous, but again, we just do the gentle massage. For the skin incision, I usually place the lateral edge of my mastectomy incision very near the axilla so that I will have an easier time accessing the axilla. Cutting time, then I do my um, skin incision, I just open up the lateral area of my mastectomy incision. So usually, when I do my mastectomy, again, it's very near the area of the anticipated sentinel node, except for cases wherein patient would want a nipple-sparing mastectomy, they would want an inframammary approach. That's only the time wherein I do a separate axilla incision. But for mastectomies and most of my skin-sparing mastectomies, I just use the lateral edge of my incision. So here you would see the blue track at the subcutaneous layer. We develop the flap. Again, I suggest you do your flaps carefully with adequate hemostasis. Your flap ideally should be above the blue lymphatics so as not to transect any of the lymphatics prematurely. So again, adequate hemostasis, careful with making your flaps because sometimes you might transect your lymphatics prematurely and you will have a hard time identifying your sentinel node. Remember, you're only using a single tracer method. Here I'm pointing out the blue lymphatics. So here you're highly dependent on the methylene blue. So you have to be very careful in preserving all the blue lymphatics. So again, do your flaps slowly and carefully. So here you'll be seeing the blue lymphatics. It's very well visualized. I actually do not have any problems with the methylene blue. I'm very used to the methylene blue and I don't usually look for the patent blue dye anymore. During my training in Singapore, we usually use the patent blue. For me, the color is very similar to the methylene blue. So, and methylene blue is so much cheaper and widely available. Again, we recommend for you to use the medical grade methylene blue. So here we proceed with the dissection. I usually dissect my flap to open up the axilla area very well. Over time, I discovered that I don't like working in small spaces. So I do my dissection or I do my flaps. So here I'm outlining the lateral border of the pectoralis major muscles. And here is the medial border of the latissimus dorsi. So this is the lateral and medial edge of my dissection. No, I was earlier pointing to the area of my anticipated sentinel node. So sometimes you will see blue lymphatics piercing through the clavipectoral fascia. So here I will be grasping the clavipectoral fascia. Now the clavipectoral fascia is usually underneath the clavipectoral fascia. It's a white fibrous fascia. So when you open it, you will usually see that the fatty area or the fats is now different above the clavipectoral fascia that still belongs to the axilla tail of the breast, and below the clavipectoral fascia that now usually you're now usually inside the axilla. So here we are dissecting. You can use cautery dissection, you can use mixture, you can use blunt dissection. Again, if you use your cautery, make sure you put it on low setting. So I'm just trying to tease out in this part the lymph node. So this is my blue sentinel node. You see the efferent and afferent lymphatics going through it. So you notice the node to be very blue. I usually put mixtures on the lymph node so that it will not fall back into the axilla. And I usually ligate with sutures the afferent and efferent vessels of the blue dye to avoid any bleeding and avoid the blue dye spilling into the um, cavity, axilla cavity. So upon further checking, we were able to see another blue node close to the initial one. So I carefully dissect it out using, again, cautery. You need to label your lymph nodes, which one is the first node, which one is the second node. So sometimes I just use one suture for the first node, two sutures for the second node, so that when the pathology reports come back, you will know which lymph node or which sentinel node turned out to be positive. Is it the first sentinel node or your second sentinel node? You also take note of the time as to when you identify the lymph node. So for this particular case, we were able to identify two very blue lymph nodes. So in the operative record, we placed two lymph nodes, both very blue, and it was sent for frozen section. Again, method technique in identifying the lymph node, the sentinel node, which is the methylene blue method. The methylene blue is readily available here in our country. It's also quite inexpensive as compared to the radio tracer alone. So after seeing the methylene blue dye technique, if you have any questions, please do not hesitate to um, type it in the chat box. I will do my best to answer it later on. So now we will now proceed to the technetium 99 tracer method alone. Now, here in Asia, and here in the Philippines, technetium 99 alone is rarely used because of the cost issues. But we tried our best to show you two videos wherein technetium 99 colloid was used as the single tracer to identify the lymph node. Now, I started using the technetium 99 alone or gamma probe alone for my patients who are undergoing skin sparing or nipple sparing mastectomy to limit the local irritation that the methylene blue leaves behind on the skin. Because sometimes I notice my plastic surgeon has to trim off some of the blue skin, and this one makes the skin envelope a little bit smaller. Now, for nipple sparing mastectomies, I noticed that the bluish discoloration sometimes brings about local irritation or erythema. And again, as much as possible, we would like to avoid any local irritation, erythema, or infection with the implant underneath. So that's why I started doing technetium 99 alone as my tracer for identifying the sentinel node. So the technetium 99 injection can be done in the nuclear medicine department in advance, or it can be done intraoperatively while the patient is asleep. Now, most patients have complained that the technetium 99 is quite painful, so sometimes we dilute it with lidocaine to lessen the pain from the injection. So if we can proceed with the video. So the first case is a 30-year-old female with a high-grade ductal carcinoma in situ 2 cm. Axilla is clear by imaging. Patient is undergoing a nipple-sparing mastectomy with immediate implant reconstruction. She requested for an inframammary incision, so I had to do a separate axilla incision. So here, this is the canister where the radiocolloid is placed. It is placed in a tuberculin syringe, and this canister is protected by lead. There's a label if it's a filtered or an unfiltered radiocolloid, and of course, it has the patient's name. This one is our handheld gamma probes. Some gamma probes have wires, so this one is a wireless gamma probe, and this one is actually the actual machine or the counter. This one is being taken care of by our nuclear medicine department, so they have usual upkeeps for these machines. This one is an example of a lymphoscintigram. The black star is the injection site, while the black dot is actually the sentinel node. So for our institution, the additional cost of a lymphoscintigram is just a few hundred pesos. So we just have it done for our patients. So this one, we are just demonstrating the injection of the technetium 99 intra-op. So it's injected in the subdermal area. They just inject about 1.1 or zero point 0.2 cc. It makes a small wheel on the breast. And then this one is followed by a 3 to 5 minute massage. Also, again, to push the technetium 99 into the lymphatics. So while this one is being done, so after that, we use our gamma probe to identify the hot area in the axilla. So this is how I use my probe. I do up, down in all areas of the axilla. And then I try to identify the one with the highest activity. Now, you have to be patient in trying to find the activity or the area with the highest activity, because this one will serve as your guide. Here we are trying to locate again in the axilla the area of the sentinel node, which means the area with the highest node. So in this part, um, I was quite satisfied as to the location of the sentinel node in the axilla. And so after this, we proceeded in prepping the patient and draping the patient. So again, arms on the side, we put a small padding at the back. And again, we also position the patient head up, and the patient is tilted away from me, just so that the breast mount falls medially and inferiorly, and it does not obstruct the area of the axilla. So for the gamma probe, the wireless one, we just use a size 8 gloves to cover it. We no longer use the uh, camera cover used in laparoscopy. So here you identify the injection site, you note the count, and again, before you make your skin incision, please re-identify the area where you find the one with the highest activity. This one is marked with the X. And for the gamma probe alone, you make your incision directly on top of that mark. When you do your incision, you dissect straight down. You do not make any flaps because your incision is directly on top of your sentinel node. If you start to make flaps, you will lose track of the sentinel node underneath. So again, very important is for you to open the clavipectoral fascia. One of the mistakes being done by surgeons who are new with the sentinel node biopsy is that they try to identify the lymph nodes above the clavipectoral fascia. So majority of the time, it is below the clavipectoral fascia. So here, I'm trying to look at or listen into the activity. So when I'm happy, I dissect the lymph node. Again, if you will see, the lymph node is very similar to the axilla fat color. And there are two mixtures to avoid the lymph node from falling back deep into the axilla. I usually ligate and tie the efferent and afferent vessels of the lymphatics. So you get an in vivo count and another ex vivo count. You get the one with you check your lymph node, it's a 10-second count. So here we're doing it away from the field. So the probe is also very sensitive. If you do your count on top of the patient, you might get the activity from the injection site. So here we're getting about an average of 1,700 or 1,800. So you note that down. And then you check again the axilla. If you notice some more activity, do not hesitate to harvest that lymph node or the second lymph node just to be sure. Again, so this is the lymph node. It's a little bit beefy red, but sometimes if it's very small, it's very hard to identify without the color blue. So again, easiest way is still the dual method. You have the tracer, you have the radio colored tracer, and then you have the methylene blue. But for this patient, we're just showing you how to do it if it's just a methylene blue, is if it is just a technetium 99 radio tracer alone. So also, I've noticed that if you use methylene blue, you're only able to identify a maximum of 1 or 2 lymph nodes. But if you use the dual method or the technetium 99, usually you identify more lymph nodes due to the gamma probe that you are using. So again, you take the in vivo and ex vivo count of your lymph node. You again label which one is the first node, the second node, and then again check very well if there is any other activity left in the axilla of the patient. So for this case, we were able to identify a third node. Again, as it progresses, the count becomes lower and lower. So here we have 3 nodes, which we will send to pathology. And we always ask pathology to do a 2 to 3 millimeter cuts. And then if we have sent them 2 or 3 lymph nodes, if ever the first lymph node is already positive for metastases, if they can call us immediately so we can proceed with the lymph node dissection. So this is the first video for the technetium 99. The second video is again technetium 99 alone. So if you can proceed with the second video, with the third video, uh, the sec- so this one is a case of a 45-year-old female invasive ductal carcinoma, 3 cm. Patient wants to go a skin sparing mastectomy with implant reconstruction. So I'm just remarking the markings from the plastic surgeon. And then here I will start to mark my axilla area. So I mark out the periareolar incision that I will be doing. And then usually I just do a lateral extension towards the axilla. I again try to palpate for the lateral margin of the pectoralis major. It's sometimes a little bit difficult for obese patients, but you'll be able to find it. So again, I push up the breast to get the crease. So this one is the lowest area of the axilla. So this one is the area where the breast goes into where the breast ends and where the axilla starts. So for my personal experience, I noticed that about 70-80% of the time, the sentinel node is located within this angle. So this one again is an example of the lymphoscintigram of the patient. There is about 2 to 3 nodes that we were able to see here. Again, this is the canister where the tracer is contained. That is actually the hands of Dr. Jonas Santiago. He will be giving us further details about the technetium 99 radiocolloid later. So we do, again, this one is just to show you the subdermal injection of the technetium 99. After which, again, breast massage is done. Usually, we only inject about 0.1 to 0.2 ml. And then before I prep the patient, I check the activity count on the primary tumor site. For this case, it's about 1,600 to 1,800. And then I try to identify the highest activity in the axilla area. So I use this technique to identify the area in the axilla with the highest tracer activity. If you're using a separate incision, again, you incise directly on top of the one with the highest activity. If you're using the lateral edge of your mastectomy flap, you need to make your flaps first before you enter the axilla. So here, our highest count is about 100. So we mark it with an X. And this is where we start our incision. For this particular case, it's a little bit unusual because our counts are quite low. But later on, we will also notice that all the counts of the sentinel nodes and the primary injection site is quite low also. So again, this one, I'm only using the lateral edge of my mastectomy scar, open go through the dermis, subcutaneous. So for patients who are a little bit obese, the subcutaneous layer is a little bit thicker. So you just open, and then again, make sure you open the clavipectoral fascia. That fascia is very important because your sentinel node is under the clavipectoral fascia. So as you dissect, you use your gamma probe to help you in determining where to open your clavipectoral fascia. So here I'm already opening the clavipectoral fascia. It's the fibrous white thing that you see me cauterizing. So there it is. So you open it. For some patients, it's quite thick. For some, it's very thin. So this is the clavipectoral fascia. So you continue opening it until you see the change in the axilla fat. So you'll see a difference between the breast fat and the axilla fat. And then again, you use your probe to direct you as to where to look for or to dissect the sentinel node. You do not have any methylene blue to help you visualize the lymph nodes. So care has to be taken in your dissection and in identifying the highest activity of your lymph nodes. So here, this is my node. This one has the highest activity. Again, I will use two mixers to lift up this area. So this area will not fall down deep into the axilla. So I usually use cautery in my dissection. Again, if you want to use cautery, do not cauterize the lymph node. Cauterize away from the lymph node. So I usually check and double check if this is really the lymph node, the sentinel node, because sometimes it may be underneath the fatty area. So these are my mixtures. I usually clamp the superior and inferior portion to help lift up the node so that it will be easier to remove and dissect. So this is my node. Again, it has no color blue. So I dissect it out. And later on, after removing this one, we will do an ex vivo count away from the patient. So one peculiar thing about your gamma probe, make sure it does not touch any of your metal instruments because it might give out a false reading. Make sure also it is away from the primary injection site. So this is the lymph node. If there's only a few fats around the lymph node, I usually do not trim it anymore. But if there are quite lots of fats, then that's the time I trim. Now the ex vivo count is almost 400 for this lymph node. So we label this as our first node. So again, you check the area if there's any other activity that you might find. So you have to check very well just to make sure. So for this case, our background activity is less than 10. So here we're quite happy that we did not leave behind any other sentinel nodes for this patient. So again, we send the lymph node for frozen section and we wait for the pathology to tell us if it's positive or negative. We, while waiting for this, that's the time we do our mastectomy. So just to reiterate, single method or dual method, you can have a very high identification rate. The blue dye as the single method is more commonly used and available here in our country. So methylene blue dye, the medical grade one, the medical grade is the one that you should use. And then equally important, patient selection and the technique, proper technique. So if you're starting out, I would always suggest smaller tumors, negative axilla by imaging, and then do dual tracer. And also keep offering your sentinel node biopsies to all eligible patients so as to increase your number. Again, practice makes perfect. So thank you for your listening. And again, if you have any questions, please feel free to ask it later during the open forum or type it in the chat box. I'll do my best to answer them. So after me, there'll be two other speakers to present their way on how they do the dual method for the Sentinel node biopsy. Thank you.
Thank you very much, Mui. That was certainly very interesting and very good. So the next surgeon to present how I do it video is he will be presenting total mastectomy with sentinel node biopsy using the dual technique. I would like to call on Dr. Joseph Thomas Noriega.
Hello, good afternoon. I'd like to welcome everybody to our first Sentinel Node workshop. For my video, I'll be showing you the dual technique wherein both the blue dye and the radio tracer are employed. Thank you. Performing the dual technique in sentinel node dissection increases the possibility of getting more nodes for analysis. This 7-minute video will demonstrate the basics of the dual technique. Our patient is a 45-year-old female diagnosed with a 2 centimeter invasive breast carcinoma at the 10 o'clock position near the nipple of the right breast. The first method is injecting blue dye. Options include isosulfan, patent, and methadone blue dyes. For this case, we use the latter. For the second method, one needs a gamma counter with probe and is usually in coordination with a nuclear medicine facility in your institution. Typically, radiotracer is injected 1 to a few hours prior to surgery or even the night prior. Lymphoscintigraphy may or may not be done depending on institutional protocols. The first step is knowing your landmarks, especially the approximate location of the sentinel node. This is a very important step as it facilitates a fluid and logical step-by-step process in successfully identifying the sentinel nodes in the given amount of time. I mark the tumor location, medial, inframammary, superior, pectoralis major, latissimus dorsi, and the approximate theoretical location of the sentinel node, which is at the axillary hairline. This is a comparison of the theoretical location of the sentinel node and our actual patient. The first step in using the gamma probe and counter is making sure that there is no interference by raising the probe away from the injection site and patient. The value should be 0. Next is checking the value of the injection site. Slowly direct the probe towards the injection site, which typically is at the periareolar area. Next is to check the site of the sentinel node at the area of the axillary hairline in between the pectoralis muscle and latissimus dorsi. Slowly direct the probe in the area, taking note of the location with the highest value, as this will be very helpful during dissection. Next is to inject blue dye. I typically inject around 2 to 3 cc of methylene blue, depending on the size of the breast, intradermal or subdermally in the periareolar region. This is followed by massaging the breast for around 5 minutes prior to cutting. Incision placement for SLNB really depends on what type of surgery you are performing. These photos are samples of a patient undergoing a central partial mastectomy, so a separate incision is done just for the sentinel node biopsy. For the case being discussed, the patient chose to undergo a total mastectomy. Usually, but not always, the incision is carried out at the superolateral portion of the mastectomy flap in order to avoid a separate incision. In other cases of mastectomy, it is acceptable to have two incisions, especially those undergoing vertical mastectomies. It would be ideal to see something like this as you incise: a blue lymph vessel leading to a blue lymph node. As you incise the superior border of the flap, carefully dissect towards the direction of the marked axillary line. Try to find a blue vessel and follow the track. As you do so, you may use the gamma probe intermittently to guide the direction of the dissection. The higher the sound it emits, the greater the value on the counter, the nearer you are to the node of interest. Once you find the node, you may excise it and label it based on the order it was taken. This, for example, is the first node excised and is therefore labeled as Sentinel Node number 1. Once the node is free from the surgical site, it can be scanned by the gamma scanner ex vivo for further confirmation. You must then document its value using the 10-second counter on the machine. Search for more sentinel nodes again by inserting the probe within the cavity and scan in an organized manner, may it be concentric or in a linear pattern, making sure that the tip of the probe is pointed away from the injection site to avoid false positive findings. It is important to note that subsequent nodes must have at least a value of 10% of the first node that was removed to be considered a hot node. Lastly, once all likely sentinel nodes have been dissected, scan the surgical field for the last time to make sure that there is no focal radioactivity present, since this presumably shows that all sentinel nodes have been removed. This is an example of how to report a sentinel node biopsy procedure. Background activity should be zero. Injection site and residual activity should be documented as well. Node number 1 is the first node removed, color blue, and with a value of 878. Node number 2 is blue, and with a value of more than 10% of the first node. Node number 3 is only blue and not hot, since value is less than 10% of the first node. Node number 4 is neither blue nor hot, but is hard and clinically suspicious. All 4 nodes are considered sentinel nodes and should be submitted for intraoperative analysis.
Thank you very much, JT. That was a wonderful. Last but not the least, I would want to call on Dr. Aldine Basa. She will also talk on the dual technique, and this time I
So we separate the node in the surrounding tissue all around as shown. I'm sorry I didn't show you the injection of the blue dye earlier. So you can test again using the gamma probe, and it will tell you the count. And then continue until you excise the node. So for me, I usually put my incision always in the same place, which is along the axillary fold below the hairline. And wherever the loudest feedback is, I just dissect towards it. I don't actually incise above the area with the loudest feedback. So this is the sentinel node that was excised. We bring it away from the breast.
Gamma probe.
Put the gamma probe on it to get a 10-second count. So each node will need to do a 10-second count. And after 10 seconds, it gives you the cumulative account. So we continue until we get all nodes that are within 10% of the highest count. Thank you.
That's a micro incision there, Aldin. If that node proved to be positive, would you have extended it for the axillary node dissection?
Definitely, yes. Yes.
Okay, thank you very much. I would like to give special thanks to those who showed their video. I know it's tedious to make those videos, and thank you again for the wonderful presentations. Okay, so as we try new techniques in surgery, we learned that we eventually find out that it's actually there are a lot of challenges along the way that we need to navigate and learn how to deal with. So I would like to call on our secretary who will discuss the pearls and pitfalls or the challenges in doing sentinel node biopsy, Dr. Felicidad Claudia Ordonez.
Hello.
Yes, Claude, we can hear you already, but we can't see you. Um, since we are ahead of schedule, maybe we can have a 5 to 10 minute break first. It's 3:12 on my time. Can we come back at 3:20 to continue with the lecture and the open forum? Thank you very much. Okay, welcome back. I hope you had time to shake your legs and take some snacks. So, welcome, Dr. Claude Ordonez.
Hey,
Uh,
ma'am.
we will now proceed with the challenges in sentinel node biopsy.
Okay, thank you. Thank you, Philippine Society of Breast Surgeons, for this invitation to be part of this workshop. So, for this afternoon, I will discuss with you how to the tips in carrying out this procedure to avoid or perhaps circumvent the challenges of sentinel node biopsy. So, one must pay close attention to technique and some patient factors that may affect the success of the surgery. Complications have to be properly discussed with patients, as always, and logistic concerns have to be arranged way before surgery. Next slide, please. So once you're already doing sentinel node biopsy, you will actually realize that it's so exciting once a blue tract or a blue node is found. It is, however, important for us to remind ourselves to check proximally, not only distally. So check proximally and distally, proximal to the tract to prevent leaving a sentinel node behind. No? So you don't want your very first sentinel node to be left in your cavity. So also, as you can see in the picture, and as many times emphasized earlier, adequate hemostasis and keeping the blue tract unsevered aid in better visualization. Next slide, please. So once in a while, patients are diagnosed via excision biopsy. If you must do surgery in a patient whose post-excision scar is at or near the area of your injection, so that would be in the areolar area or sometimes in the upper outer quadrant, or if you have a patient with, on whom you plan to inject peritumorally, please do take this in mind. Inject away. Okay, so away from the excision site, away from the tumor. This way, you don't inject into the cavity itself or into the tumor itself. Next slide, please. For patients with tumors in the upper outer quadrant, the shine through phenomenon or false gamma counter signals can sometimes be a concern. It would be therefore better to inject the radioactive dye subareolarly in these patients. So in case injection has already been done and it has been done peritumorally, you may prevent the shine-through phenomenon by directing the probe away from the injection site and make sure to direct it directly downwards. So it has to be 90 degrees downwards. Next slide. So the T must be reminded that the gamma probe setting should always be checked. Well, this is routinely done, but keep in mind that you have to check the settings. Setting the counts too high or too low may give erroneous readings. And actually, when scheduling for dye injection, the nuc med department will always ask for the time of surgery because timing is very important. For early morning surgeries, injection may be performed sometimes late in the day before or the night prior. But for midday surgeries, often they will inject the morning of that day. So later, Dr. Jonas Santiago, our med specialist, will elucidate this further. Next slide, please. It is expected that for women with large breasts, the dye may take more time to travel. So you may use as much as 4 to 5 cc of methylene blue or blue dye and massage for more than 5 minutes. So I usually use maybe 1 cc of methylene blue and I mix it with plain NSS to make it more neon blue when I use my methylene blue. And I can give as much as 5 cc for patients with larger breasts. And just as you keep in mind of the 30-minute dissection time until you see the first node. You can you can massage for longer than 5 minutes. Maybe it can take 7 to 10 minutes. Okay, next slide, please. Pre-op preparation, as we all know, is of paramount importance in surgery. So patients with history of allergy or asthma should be advised as to the possible allergic reactions, though they may be uncommon. Symptoms may be as mild as urticaria or rash, or can be as severe as to cause hypotension or even pulmonary edema. In these cases, methylene blue may be used as risk for allergy to methylene blue is extremely low in comparison to your patent blue and your isosulfan blue dye. Next slide, please. So for patients with a heavy history of allergy, pre-medications such as your diphenhydramine or your steroids may be given. Also, for those who do day surgery, it is advisable that the patient be admitted and not undergo day surgery. Next slide, please. Advise your patients, especially those undergoing breast conservation, that tattooing, necrosis, or even blue breasts may occur. So this happens when your methylene blue is injected superficially or intradermally. This complication may last for as long as 1 year. And when it happens, it is important to just assure your patients, ensure adequate hydration, and if warranted, administer topical antibiotics. Next slide, please. So this patient underwent breast conservation surgery with sentinel node biopsy. Unfortunately, the patient has developed a small area of necrosis at the upper outer quadrant of the areola, as you can see. The necrosis sloughed off after a few months, and if you will see, there's also a bit of a blue hue. The blue hue took around 6 months to fully disappear. Also, it's important, as they already mentioned in the technique a while ago, that the blue dye may alter light absorbency of the blood. So please prepare your anesthesiologist, because they may report to you intraoperatively that your patient is experiencing desaturation. So of course, the first thing to do is to make sure that there are no other causes before it is safe to assume that it is a false desaturation. So remember to always advise the entire team of the possible occurrences of the procedure. Next slide, please. Sentinel node biopsy, we can never emphasize enough that sentinel node biopsy is multidisciplinary. Not all institutions, however, will have validated specialists in the team for SLNB. So it is important that the team as a whole undergo validation. So this is an institutional endeavor to be able to carry out this procedure with minimal complication or challenges. An established MDT team increases the chance of successful breast surgery. Availability of the dye and or the tracer may also be an issue, which has to be taken care of if an institution decides to carry out this procedure. So compared to patent blue dye, the methylene blue is now readily available, even the medical grade, the ones in the ampoule. So with that, thank you. We hope that these tips and reminders will help you once you start doing your sentinel node biopsy. Thank you, ma'am.
Okay. May I call on the past lecturers? So we will now open the floor for questions on sentinel node biopsy regarding the earlier topics discussed.
from the upper and lower levels of the axilla. If you superimpose actually the location of the ICB and the median pectoral node against the level of the axilla, you will see when you do your dissection that it actually lies, both of these nerves actually lie below the pectoralis minor muscle, which is your level one. So you don't overdo your um, sentinel lymph node biopsy and you don't go to the higher level if you find this nerve very important nerves.
So based on all the discussions that had been uh, that went before this, we would say that the location of the Sentinel node is fairly consistent, right, across.
Yes. Before there was a controversy and there were opponents of that. They said that you can't predict the lymphatic flow of the breast, but because of this various different studies, they actually found out and discovered that breast lymphatics actually has an orderly fashion. So it starts from the breast lymphatics from the skin down to the subareolar plexus, and then it goes to the external mammary up to the level of the intercostal brachial nerve and median pectoral nerve. And these are all considered as at the lower level of the axilla, which is level one.
Okay.
If we will really dissect on the anatomy, the ICBN actually branches out from the second intercostal nerve, and then it goes through it becomes your ICBN, and that's the one that goes to your medial arm. And this all the surgeons, even general surgeons, usually would encounter that when they do mastectomy on the lateral dissection. And if you talk about median pectoral nerve, which is the other nerve that I mentioned, um, it actually pierces through the pectoralis minor muscle, and laterally it goes through the posterior aspect of the axillary artery and vein. So these are all consistent with what we now know and what Dr. Giuliano had introduced to us, that uh, the sentinel lymph nodes, which are the first draining node, whether they're identified through blue dye or radioisotope, are actually just located at level one.
Okay. Thank you. So I would like to ask this question to everyone. Uh, where do you exactly inject your dye? Do you inject subdermally, subareolary, or peritumoral? And what is your experience if you've tried doing several in combination ba o single area lang kayo nag-inject, and what is your experience? Kung sino mauna. What do you think is the most consistent in terms of identifying your sentinel nodes? Because all of these areas of injection are mentioned in the books, in the literature. So based on your experience, where do you prefer to inject? Like, would not injecting peritumorally decreases your identification rate or not?
Yeah.
Please comment.
Do I answer also that, Dr. Mateo?
Everyone, since ang tanong ko experience, sige, pares muna
Because
natin si Remy. We'll
yeah.
others
but
first.
but I can answer also because it's related to the anatomy as well.
Yeah, okay. Sige, kung sino gusto mauna. Experience naman eh. So, para we
Yeah.
can share.
Yeah, I think the most consistent, and everyone may agree with me also. I hope they will agree with me that the most consistent is when you inject it subareolar, because that's where the we find the very rich lymphatic network of the breast. And the danger, okay, it's not wrong to do injection around the tumor or the peritumoral area, but the danger is when your needle goes through the tumor and it doesn't travel very well. So the other method that I find very easy and that will really make the blue dye or even the rage tracer travel very well is your intradermal injection, because as I've mentioned, the lymphatics of the breast commences on the superficial dermis. So if you do your intradermal injection, it will definitely follow the route of the travel of the blue dye towards the lymphatics, which is towards the axilla.
So saan mo gusto?
Subareolar plexus
Subareolar. The others, please.
and intradermal combination.
Combination.
Me, ma'am, I usually inject subareolarly, but for I rarely do peritumorally. But however, for patients with tumors or an excision biopsy scar in the upper outer quadrant, aside from my subareolar injection, I add an intradermal injection, maybe
Okay.
1 cc, just to make sure that the methylene blue will reach the sentinel nodes. Although this can be a problem for patients who undergo BCS, because as you know that if you inject too superficially, you can have tattooing or even necrosis.
Yeah. Let me add to my questions para pag nagsalita kayo lahat sagutin niyo na, no? So, that's one. Yung where do you prefer to inject? Number two is, do you dilute and how much of a dilution do you use? And do you make adjustments if you are doing the BCS as compared to injecting when your plan is to do a mastectomy? So,
Um, for me, kasi I was trained using the patent blue dye. And previously, the patent blue dye was not very expensive and methylene blue couldn't be found. No? But now that the patent blue is expensive and the methylene blue is more accessible, I have found out that mixing the methylene blue with plain NSS or maybe sterile water makes the color that the blue hue more similar to the patent blue dye, because the patent blue dye is actually more of a neon or a turquoise blue. No, so it's really you can see it quickly. If I use the methylene blue na as is lang, sometimes you can also mahirap ma-view kasi sometimes you can mistake it for um, mukha siyang Venus na yung track, no. Um what else? So there, I usually, because I most of the time use methylene blue now, I mix it. So I use around 3 cc to 5 cc depending on the size of the breast of the patient.
and what is your dilution?
There's no standard actually. So I use 1:4.
Okay.
1 cc of the methylene blue and then 4 cc of the plain NSS or the sterile water.
What about the others? You can choose to answer only one of my questions each. Baka sobrang haba eh.
So,
Sige.
Dr. Pagdanganan, with regards to your question, personally, um, I have never done any peritumoral injection for the methylene blue dye. During my training, we were also trained to do in the subdermal area, periareolar region. So that's where I usually inject my methylene blue dye, especially if I'm just doing a mastectomy, because the blue skin will be removed together with the mastectomy incision. Now, I just modify my technique of injecting methylene blue if I am doing a nipple sparing or a skin sparing mastectomy, so as to lessen the chances of the methylene blue being retained on the skin, which we all know is a local irritant. So I do inject subareolarly a little bit deeper, so that hopefully there will be less staining of the skin with the methylene blue. Because I noticed that the plastic surgeon, if they notice a very deep colored blue edge of their skin, they tend to remove it. And so it will make the skin envelope a little bit smaller, which we'd like to preserve as much skin as possible for cosmesis. And usually, if I'm doing dual tracer, technetium 99 with methylene blue, my methylene blue is very diluted. I just do 1 ml of methylene blue with 4 ml or even 5 ml of plain NSS. What I'm after is the volume to be injected, because especially if the patient is quite big. So I need more volume to travel to the axilla area.
Okay.
What else? So again, I have never done any peritumoral injection. And I'm very happy actually with the methylene blue. I do agree with Dr. Ordonez that if you mix the methylene blue with the plain NSS, it will appear like a neon blue in the lymph node. It will not be very hard to identify. Last time they said it's a little bit harder to identify the lymph node using methylene blue, but personally I have no problems in identifying the blue tract nor the blue sentinel node. It's very obvious. Yeah.
Okay. So who else wants to say something? Borge. Wala yatang question sa history eh. Sumagot ka na dyan. Okay.
Thank you, Doc. I For sentinel lymph node biopsy, I only use uh, one method, only the blue dye method. Since before I was only using patent blue because I was trained to do such. But since patent blue is not that readily available in Davao City, methylene blue was much more common. So I've used methylene blue, and most of my patients I inject it subareolarly, not peritumorally. I haven't done any sentinel lymph node and then injecting the blue dye peritumorally. I haven't experienced that.
Okay. Who else?
For
Uh,
me, ma'am,
yes.
for
JT.
me, ma'am, I've actually tried a lot of methods for the Sentinel node. I've tried intradermal, subareolar, and peritumoral, but the injection site should be on the skin above the tumor with consistent and fairly consistent results. I could find the nodes easily, even if the dye was injected on the skin above the tumor. I usually inject either pure methylene blue or a diluted 1:1, especially if I'm performing nipple sparing mastectomy subareolarly. I inject it diluted with consistent results. Thank you.
Okay. Aldine. Ikaw nakatapat sa akin. Oh.
I always inject subareolar. Um, I prefer that because if you're conserving the patient and you do it above the tumor, everything is blue, so it's very messy. When you do a mastectomy, the blue dye goes with the mastectomy skin. So I always do subareolar. I've always used patent blue. I don't really use methylene blue, but just recently, because as you know, the patent blue was pulled out, and all that's available right now is methylene blue. I did one case, my one case with methylene blue. So I find you have to inject deeper than what we usually do for the patent blue. But I'm always subareolar for all my patients.
Okay. Who else? Who else wants to? Who has not answered? Or is the next questions na? Uh, Che, are you going to say something?
I also inject in the subareolar area. I find it better identification rate of my sentinel node node. Yeah.
Yeah, because I read somewhere that there's some lymphatics that come exclusively from the parenchyma of the breast, and that would account. So since most doctors would use subareolar injection, this accounts for the non-identification rate of less than 5%. Kasi you injected subareolarly compared to injecting it peritumorally. However, yung sa pitfalls niya, mas marami talaga yung accidentally injects into the cavity of the excision biopsy, and so you also fail to identify sentinel lymph node. Okay, so do we have questions from the audience? Ella?
Hi, Doctora. Good afternoon. Yeah, we have several actually, most of which are directed towards the clinical application of the sentinel node um, biopsy. We have one question from Doctora Jen Mercado, but the question is directed to Doctora Sherry Lee. The question is, what is your comment regarding the latest NCCN guidelines on the indication for sentinel lymph node biopsy with suspicious 1 to 2 nodes on imaging?
Uh, Usually on clinically node negative but suspicious on imaging or on needle biopsy, they found out that there was positive for malignancy as long as it's only 1 to 2 lymph node. It's also important to clip the lymph node. You can be eligible for a sentinel lymph node biopsy if they meet the criteria of the ACOSOG C11 trial. The applicability of the ACOSOG C11 would be if the patient is for breast conservation or lumpectomy, patient with T1 or T2 tumors, a clinical negative axilla, 1 or 2 positive lymph node without evidence of significant capsular invasion, if patient agrees to a complete whole breast radiation, and if patient agrees to a complete adjuvant systemic therapy after the surgery.
Thank you, Dr. Meron pa. So, Dr., the question is from Dr. Batara. How about the lymphatic invasion seen on corneal biopsy of the actual breast lesion? Does it predict the positivity in sentinel lymph node biopsy?
Uh,
I think, Francis.
can-
The LVI,
oh, go ahead, Dr. Frances.
the presence of LVI predicts positivity in the sentinel node, definitely, but it does not preclude the patient from undergoing a sentinel node biopsy. So if you have LVI, clinically negative axilla, then you might say that there's a higher chance for positivity in the sentinel node, but then you can still do the procedure.
Yeah.
And Doc, I
Can
think
I
I'm
add?
less intradermal and periareolar. I just didn't make a comment. Most of the time, I do periareolar and intradermal.
Okay.
I also want to add a comment regarding the question of suspicious nodes on imaging. The NCCN also states that if you have a suspicious node on imaging, is that you will have the patient will need to undergo fine needle aspiration biopsy to confirm if it's really metastatic or not. If it's negative, then the patient is eligible for sentinel node biopsy.
Okay, so it's better to know preoperatively if it's positive or not, right? JT, is that what you're
Yes,
saying?
ma'am. Yes, ma'am.
And in addition, Doc, I think there's a big difference in being clinically positive or clinically negative.
Yes.
Right. Okay. So it was mentioned that the indications for sentinel node biopsies T1 and 2, T2, and it is contraindicated in inflammatory breast cancers. What about in T3 and T4 lesions? Can we do sentinel node biopsy in T3 and T4 lesions?
Uh, Actually, the patient can do neoadjuvant chemotherapy for if they are desiring to have the sentinel node biopsy after.
But upfront surgery, you would not recommend the T3, T4 patients with T3, T4 lesions to undergo sentinel node biopsy, right?
Dr. Marcel.
Yes.
Yeah, there's actually a study by Dr. Giuliano about the T3 tumors. So I think he mentioned it when he visited Manila. T3 tumor meaning you have more than 5 centimeter tumor. So he and his colleagues actually did a study on that, and they subjected patients to undergo sentinel lymph node biopsy, and they found out that more than 70% of those patients who are T3 who have T3 tumors actually had a positive uh, uh, findings on histology of the axillary lymph node. And if you also look at if it's T3, the like percent of axillary involvement is very high, which is about on I think 67% already.
So it's not indicated.
Yeah,
Okay.
I would prefer not to.
Yes. Thank you. Thank you for that. Ella, any other questions?
Doctor, actually. So if we can continue po. So there's one question from Dr. Alex Tan, connected to the indications for doing SLNB, would you do sentinel?
Be fatty hilum, loss of fatty hilum, and also I look at the thickness of the cortex. So ideally, it's just about 1 to 2 mm thick. Sometimes you might see some cortex of the lymph nodes to be at least 3 to 4 mm thick, and then the fatty hilum is already very small. So that one already alerts me that there's a possibility that that lymph node may contain cancer cells. So either I proceed with a fine needle aspiration biopsy of that lymph node, or I omit the sentinel node biopsy altogether, especially if my primary tumor is already 5 cm or more. So again, I do agree with Dr. De La Serna that there are other factors that you look into the lymph node aside from the echogenicity of the hilum. I also look into the cortex and into the shape of the lymph node plus the other surrounding lymph nodes.
And I think that's why it's very important to have a specialist in radiology. You should have a breast radiologist because you cannot just report how the node looks like. You have to put in your findings if it's suspicious or not, because that will guide the surgeons as well.
Actually, I would personally encourage the surgeons to look into the actual ultrasound images yourself so that you can correlate the ultrasound imaging and with a histopathologic finding of that lymph node. The limitation of the radiologist is that they only see the images and they just describe it for us. But for us surgeons, once you see the images of your lymph node or your tumor and then you correlate it with the histopathologic diagnosis, it puts you in an advantage so that in the future, if you see such characteristics of certain lymph nodes, then you will be more confident to leaning towards if it is involved or not. So that's my suggestion to most surgeons. Always look at your images.
So both of you agree that if there's a really clinical or suspicion and imaging that it's a positive node, we proceed with needle biopsy, just like what JT will do, right?
Yes, a fine needle aspiration biopsy.
Fine needle aspiration biopsy.
May I add to that?
Okay.
Okay, I agree with Frances and what Moy has said. No, if in doubt and you are really suspecting axillary node positivity, you can either do an FNAC or a core needle biopsy of the axillary node, or just do away with the sentinel node biopsy. Actually, there's also just for it would be good to know that there's actually a nomogram by the Memorial Sloan Kettering, for us to be able to predict the chance of a possible sentinel node biopsy. So this would be multifocality, the size of the tumor, the breast panel. So just to emphasize what Francis was saying, we have to take a lot of things into consideration before we decide whether this node is really suspicious or not. That's it.
Okay. So we mentioned about the size of the mass and the suspicious node. When is I would just like to ask or to for you to summarize, when is sentinel node biopsy indicated in patients who underwent neoadjuvant chemotherapy? And what are the factors or what are the steps that need to be done for us to consider doing sentinel node on that patient, and whether we have done the sentinel node biopsy in a post neoadjuvant patient adequately and correctly?
Doctora, sorry if I may, there's a correlating question from Doctora Mercado regarding that. If we have a case with a T4N1 patient who underwent neoadjuvant chemotherapy and then the patient became clinically negative after the neoadjuvant chemotherapy, would you still do SLNB in correlation to your question?
So the question is, when do you consider doing sentinel node biopsy in a patient post neoadjuvant chemotherapy, after neoadjuvant chemotherapy, and what are the essential things that needs to be done or accomplished to consider your your performance of sentinel node biopsy as correct?
Yes, Dr. Thank you po.
So who wants to answer the question?
Actually, I'll be my next lecture is about this
Okay.
question.
So
But Jan,
mag-teaser ka na, JT.
summary, there are actually large scale studies already regarding this, and they found in other studies that when it is discouraged to do sentinel node biopsy in certain cases, like if you have uh, a tumor that has not responded well, if you have clinically positive nodes, these are contraindications to sentinel node biopsy after neoadjuvant chemotherapy. If you are going to do the neoadjuvant, if you are going to perform sentinel node biopsy on a patient that has underwent neoadjuvant chemotherapy, then number one, you should be using the dual technique. Number two is that the patient should be clinically node negative. Uh, And then number three, if you have nodes on permanent section that are either positive or presence of micrometastasis or ITCs, then these are indications for axillary dissection. Unlike patients who have not undergone neoadjuvant chemotherapy. And lastly, the minimum number of nodes should be three.
I think we all agree on that, so I would not be asking the others anymore. There is a question here that is related to that. There was an earlier mention of leaving a clip or marker. So, what is the purpose of that? How could it enhance the accuracy of the sentinel node biopsy? So, who wants to answer that?
Uh, can I answer?
Yes, yes, Aldine.
So, if you have a patient with clinically positive lymph nodes and you give neoadjuvant chemotherapy and you still want to do a sentinel node biopsy, if this patient has responded, then we should biopsy the nodes that are clinically positive and put a clip in those nodes. After the neoadjuvant chemotherapy, if these nodes have responded, then you can do your sentinel node biopsy. But what is being recommended now for this scenario is, apart from doing your usual sentinel node biopsy where you use a dual technique and look for the nodes that are positive, that are blue or hot and blue, you have to look for the nodes with a clip in them and remove them as well. So now they're calling this a limited axillary dissection because you're doing actually more than a sentinel node biopsy, because sometimes the nodes that you've clipped are not the sentinel nodes. So usually this is the scenario where you would do the clipping of the nodes.
Okay. Anyone who would like to add to that?
And not a lot of centers do this because a few experts would say that they have a hard time looking for the clip node.
Yeah.
First thing, how do you locate the node? So you have sometimes you have to put in a needle. You put in a needle to that clip node, and then you do the dissection, and you take out the clip node using the needle as a guide, and that's very difficult. And then I think there was just one center which did the targeted axillary dissection, and they could not reproduce the same results. They had very good results, and others would have just a 60% chance of taking out the clip node. So that's the reason why I think the targeted axillary dissection, not a lot of people do it.
Okay. So moving on, I noticed that most of those who presented videos on how they do the sentinel node biopsy used cautery in the axilla. Does it not interfere with the identification of blue lymphatic, since sometimes when you cauterize there's a discoloration or dark discoloration of some tissues in the axilla? What is your setting? What is the setting that you use when you do sentinel node, when you use cautery in doing the sentinel node biopsy?
Dr. Pagdanganan, so personally, I usually use the cautery. When I make my flaps, my cautery setting is a little bit high. it's on 25 to 30. But when I go around into the axilla, when I dissect the lymph node, I always lower it down to 15 to 20 only. Again, this is to limit any burning of any lymph nodes. So I also do not have any hard time distinguishing between cautery burns from the blue lymphatics. Again, so far the methylene blue has worked very well for me. So it's more of trying to follow the correct blue track and ensuring adequate hemostasis.
When you say 15 to 20, are you referring to cutting or coag? Or do
Uh,
you use a combination of both?
I just use a pure 15 to 20 coagulation. My cutting is usually 1 or just 0 when I go into the axilla. For my flaps, again, it's a little bit high, 25 to 30. But so far, no issues. I'm actually quite curious with Dr. Noriega as to the use of the ultrasonic shears.
Yes. So for me naman, ma'am,
Mayaman eh. Mayaman na bata. Okay.
most of my surgeries, ma'am, I use either the Covidian ligature or the competitor. But I do also use sometimes purely cautery. And as long as you have a good method of doing the Sentinel node and you have a blue track, I don't think it will be a problem in using cautery.
With the regular cautery, what is your setting?
It's the same as Dr. Michelle Uy po.
15 to 20 coag. How about you, Aldin? I noticed that you also use
Yeah, I just use cautery. I don't use ligature, and my setting is usually 20. And so you usually avoid the lymphatic, and if you see one, I have my assistant clamp it with debaki or with mosquito, and then I burn it. Because if you just cut through it, the blue dye may spill and contaminate the area. So usually the assistant will clamp it, and I just burn it, and it seals it off. But I use cautery throughout the procedure with no problems.
uh there's a question from the audience asking us to compare the two techniques. Actually, there are three techniques. One is the use of blue dye alone. The other one is the use of radiocolloid isotope alone, and the dual combination. Will you please expound on the sensitivity, specificity of each of the techniques?
Um,
Uh,
as, as mentioned earlier, actually, the dual method is complementary. Neither the definitely with the use of dual method, you have a higher identification rate, but a recent systematic review actually showed that the false negative rate of using a dual and the single modality is the same. So what matters, I think, is the expertise. You should master the technique. You try to get not just one node. You try to get minimum of 4 to 5 nodes. And in terms of specificity and sensitivity, definitely the blue dye alone has a lower sensitivity and specificity, but despite that, the false negative rate is the same at expert hands. So I guess the decision on what tracer to use would depend on the surgeon's preference, what technique is mastered. It would depend on the availability of the nuclear medicine facility and also if the patient can afford. Actually, in Cebu, it costs so much to do a dual tracer. Um, there's an additional 70,000 if we want to use a gamma probe, and that's the reason why for post-neoadjuvant chemo patients, even for clinically negative patients, I do an outright axillary lymph node dissection. You have to, what's important, you have to master the technique.
okay. Another thing that needs to be emphasized, or this is a question that is very relevant. When do you stop looking for blue nodes in relation to your injection time?
So as
When do
mentioned,
you stop looking for blue nodes?
so it should be from the time of incision, you should just have 30 minutes to look for the blue node. You should be able to send the specimen already in 30 minutes.
And when you have removed all the blue and all the hot nodes, but you can feel a palpable node in the axilla, do you consider them a sentinel? Do you remove them and send them for pathologic examination too?
Yes, a palpable suspicious node is a sentinel node. So you should remove all the nodes which are which which is within the definition of a sentinel node.
Can somebody please repeat the definition of a sentinel node? I mean, what
It's
So,
a
do we consider sentinel nodes intraoperatively?
so
uh,
a sentinel, I'll answer that for you,
mhm.
Dr. De La Serna. So again, a sentinel node is any blue node, any hot node, any blue or hot node, any blue lymphatic leading to a node, or any palpable suspicious nodes. So those are the definition of your sentinel node. So even if it's only blue or only hot or both, or the node did not light up but it's a blue track leading to a node, so those are considered sentinel nodes. And even after you have removed any blue or hot nodes or any blue lymphatics leading to a node, you still feel some palpable nodes, suspicious, enlarged, you still need to remove that and send it for testing. So that's your definition of a sentinel node.
And never forget about the 30-minute time that you have to look for the blue node.
That is, the 30 minutes is in reference to the blue dye, right? To the blue dye.
Yes,
So
the
to
30 minutes is in
use that,
reference to the blue dye because
yes,
the blue dye can wash out beyond 30 minutes. So beyond 30 minutes, if you see other blue nodes, you might be already seeing higher level of nodes, which may no longer be your sentinel nodes. Because you will notice if you have, after you have removed your sentinel node, sent it for pathology, and then you proceed with your mastectomy, later on, if you recheck your axilla, you might see some blue tracks or blue nodes deeper into the axilla. These are no longer considered your sentinel nodes because it has, way past the 30-minute time. So most likely the blue dye has traveled into the higher level of nodes.
Boy, I have a question. What if you're doing the dissection and during the course of a dissection at the axillary tail, you found a big palpable node? Would you still send it for frozen section or would you just leave it behind? Or would you take it out and just send it for final pathology? You have a big node at the lateral aspect of the specimen.
I usually remove and send it for frozen section.
okay.
So this one, because any superficial lymph nodes can also be reactive from the previous biopsy. So even if it did not light up, but it's there, it's big. So I usually send it for frozen section.
Okay. Agree. Agree. Ella, my Google Docs won't update. Can you, are there
Yes,
any other
Doctor.
questions from your end?
Yes, Dr. may question for Dr. Gozali regarding the use of ICG in the cyanin green in SLNB. Do we have any experience about this?
Do you have any experiences, people? Definitely, it's more and more people are using it. It's an alternative to the use of radioisotope. It's for those centers which do not have nuclear medicine facility. So you just inject the indocyanine green, and there's a special camera for that. Um, we I don't know if any one of you has used indocyanine green.
I have used ICG using the SPY-FI, the camera that you direct in that area to look at it. What I found is the detection rate is the same, but I found that the travel of the ICG to the sentinel node took so long compared to your blue dye. So I'm very impatient. So I prefer the blue dye because the ICG took a long time for me.
Dr.
And is
Aldine,
it
how
true?
long did it take for the ICG to travel?
And is it true,
20
Aldi, that
minutes.
there's more scatter with the ICG
No,
compared to the blue dye?
no, it's really green. It's very, very nice to look at it. It's very, very green and it looks really good. It's very easy to look for it, but it just took so long
How
for
long
it
did
to
it take?
travel.
How
For
long?
my case, it took 20 minutes, so I was like, really impatient.
Cost-wise, what is the difference between the ICG and the radio isotope dye, the technetium colloid?
ICG is cheap, but they'd have to buy the SPI-Fi, so that costs a lot. So it depends on how the hospital will charge that. But I think it turns out actually cheaper. Yeah.
Okay. Another question for well, it just needs emphasis, Claude, with regards to the use of the probe.
Yes, ma'am.
It is very sensitive as to the direction. So, can you elaborate again on how it should be positioned when doing the sentinel node biopsy?
When doing your sentinel node biopsy, no, actually Moy has shown us how she does it, no, with her video. You have to, prior to incision, you have to pan it in different directions. So you always direct the probe away from the tumor or the injection site, no, and it has to be directly downwards 90 degrees dapat, so that the shine through phenomenon is prevented. Also, you have to scan the entire axillary area before you decide on which area the sentinel node lies. So yun, usually the NUCMED specialist will also be with you intraoperatively. So for those who are starting, no, the NUCMED specialists will also help you read the counts on the Geiger counter.
Yes, we have to also be train ourselves to move very, very slowly, millimeter by millimeter movement to pick up where it will sound.
Yes, ma'am.
Louder,
It
right?
has to be done really slowly. Sometimes you will note that, a minor deviation from your previous area will cause a marked difference in the counts that you can see on the counter, no. So, well, practice makes perfect. So it can be very confusing in the beginning, but as we go along, you can easily do it.
Any other questions, Ella?
Yes, Doctor. I think there were a few questions regarding um, positive sentinel lymph node on permanent section po. How will you proceed with completion axillary lymph node dissection? I think this is connected to ECOSOL Z11, the AMERS trial, and the IBCSG 2301 trials that we have.
So the question is post mastectomy or post lumpectomy, 1 out of 4 nodes positive on permanent section.
Yes, Doctora. Will you proceed with completion axillary lymph node dissection?
You mean will you go back for completion? So I think we can divide this question, like for
Yes.
example, intraoperatively you get a 1 out of 4 positive lymph nodes intraoperatively. Will you
Yes.
proceed with axillary node dissection? That's the
Yes.
first. Let them answer first.
Thank you, Doctora.
Intraoperatively, you were able to identify 1 out of your 4 sentinel lymph nodes to be positive. What do you do?
Well, if the
Well,
patient is undergoing breast conserving surgery, I won't do an axillary dissection anymore. But if this is a mastectomy patient, yes, I would do an axillary dissection.
What about the others? Agree? Everybody agrees?
I would do the same.
Okay. So, say a week after the surgery, the histopath permanent section comes out, 1 out of 4 nodes positive. What will you do? Will you go back for a completion axillary dissection or not?
So
Two scenarios: patient undergoing BCS and a patient undergoing mastectomy.
for patients who are undergoing breast conserving surgery, then no, you can just do post-op radiotherapy on the patient. For patients undergoing mastectomy is a bit controversial. So the standard uh, the standard protocol now is to do a completion axillary dissection. But for patients who refuse radiation, it is acceptable to do post-op radiation because one of the trials, the Amoros, included around 17% were mastectomy patients. And it is an acceptable alternative to patients who do not want axillary lymph node dissection.
Anyone from the panel who do not agree, who doesn't agree with JT? So everybody
Um,
agree.
Dr. Pagdaran, so I do agree with Dr. Noriega. You may go back, do completion axillary lymph node dissection, or you may offer radiotherapy after. Now, there are some cases, again, some cases wherein if patient is not amenable for both surgery, completion axillary dissection, nor the radiation therapy, and I look into the patient's factors. Again, if only one sentinel node is positive out of the four, I have a small tumor, hormone positive, HER2 negative, Ki67 is low, grade 1, grade 2 tumor, patient is elderly, I'm a little bit more lenient in allowing them to do just observation for these patients who are highly likely not to have a recurrence. But again, still, I will still push for either lymph node dissection or radiation. But in case there might be other factors that again prevents us from doing radiation or completion axillary dissection, I look very well into patient factors and explain their risk. So if it's low risk, and if they really refuse radiation or surgery, we just tell them that um, you need to watch out very well in case there might be any enlarged lymph nodes in your future scanning. Then we will do completion lymph node dissection.
Regardless of whether you have ITCs, micromets, or macromets,
For ITCs or micromets, I'm more lenient. But for
even with
macromets,
high risk
yeah,
factors.
where I also look into the other factors. Of
No,
course, I do discuss all these risks with the patient. As long as they understand, they really refuse, then it's just a matter of explaining their risk.
And for ITC and micromets, and the patient has not undergone neoadjuvant chemo, there is no need to do an axillary lymph node dissection.
with mastectomy.
Yes.
Yes.
You only need to
Then
do it
with
post.
not so benign tumor factors.
Yes.
Okay. Kunwari, histologic grade 3, nuclear grade 3, pero may ITC ka doon, nagmastectomy yung patient.
Basta
Hindi pa rin.
not post neoadjuvant chemo, doc, ha? There's still no indication to do axillary lymph node dissection. They have studies on that. It does not impact overall survival or disease-free survival.
Okay, thank you very much. Any other questions, Ella?
Yes, Doctor.
Yeah, okay.
Madami-dami pa.
Oo.
Okay, actually, these are more on...
last two questions na lang.
Okay.
Marami pa ba?
Actually, yes po. Actually, there's a series of questions from Dr. Ralph Yap. So let's start with the first one. The first question is, in institutions without nuclear med facility, how can a general surgeon start with utilizing SLNB in practice using blue dye method only? So what is the learning curve now for the GS?
Okay. Can we answer that later? Because is that part of your lecture later, Aldin?
Yes.
Okay, later,
So
Doctor.
we will have Aldin collate everything, put everything that we learned today.
Okay, Doctor. From Dr. Claparol naman po, his
of Clinical Oncology, or ASCO guidelines. In patients who are otherwise Z11 eligible, there is no evidence to suggest that the status of the ER and PR receptors and HER2 receptors is relevant to the accuracy of SLNB or to the need for completion ALND. There is no need to perform ALND in patients with early breast cancer who do not have nodal metastasis on SLNB, including those with isolated tumor cells present in the sentinel nodes. 7 randomized trials compared patients with early breast cancer who underwent SLNB first, followed by ALND, only if SLNB was positive, with those who underwent outright ALND. Compared with outright ALND, SLNB first, followed by selective ALND in patients with positive sentinel lymph nodes, resulted in similar overall survival, disease-free survival, and disease recurrence rates, but fewer adverse events and better quality of life. This conclusion is best illustrated by the results of the National Surgical Adjuvant Breast and Bowel Project, or NSABP B32 trial, which included the largest number of patients of all the trials. The NSABP B32 trial enrolled 5,611 early stage breast cancer patients with clinically negative nodes and compared SLNB followed by ALND with SLNB followed by LND only if the sentinel node biopsy was positive. SLNB was successfully performed in 97% of patients, and the false negative rate was 9.8%, and no significant differences were observed in regional control, overall survival, and disease free survival between the groups, and a median follow up period of almost 8 years. Occult metastasis refers to tumor cells in the lymph nodes that are not seen on initial H&E examination, but are detected subsequently by examining additional levels or by performing immunohistochemistry staining or reverse transcriptase polymerase chain reaction. In patients with occult metastasis found by SLNB, no completion ALND is needed, and no alteration in subsequent adjuvant therapy is recommended. Clinical trials have examined the significance of occult metastasis in sentinel nodes. Although the NSABP B32 trial demonstrated that the presence of occult metastasis was associated with a 1.2% lower overall survival rate and a 2.8% lower disease-free survival rate, patients with occult metastasis did not have a higher incidence of regional or distant recurrences. The American College of Surgeons Oncology Group, or ACOSOG Z10 trial, found a 0.6% lower overall survival rate in patients with occult metastasis, but this was not statistically significant. Both trials demonstrated similar outcomes related to occult metastasis. In addition, the occult metastasis detected were almost entirely isolated tumor cell clusters, or micrometastases, and only rarely macrometastasis. The International Breast Cancer Group, or IBCSG Trial 2301, is a randomized multicenter phase 3 clinical trial comparing axillary lymph node dissection with no further surgery for patients with sentinel node micrometastasis. There was no statistically significant difference in the 5-year disease-free survival and overall survival rates between the two groups. The conclusion, ALND may be avoided in early breast cancer and limited SLN involvement. There is compelling evidence that ALND is not necessary in most women with early stage breast cancer who have only 1 to 2 sentinel node metastases and who will receive whole breast irradiation as part of breast conserving therapy. If, however, whole breast irradiation is not planned, then ALND is indicated for such patients. Historically, patients with any nodal metastasis underwent completion ALND. However, only approximately 40% of patients with a positive sentinel lymph node had residual disease in the axilla. The rest derived no benefit from the addition of ALND. 2 randomized trials, the ACOSOG Z11 trial and the International Breast Cancer Study Group 2301 or IBCSG 2301 trial demonstrated that many of these patients with one or two metastatic sentinel nodes can safely avoid a completion axillary node dissection. The ACOSOG Z11 trial by Giuliano et al. Was designed to address the need for completion ALND for patients with T1 or T2 breast cancer who were clinically node negative and had fewer than three positive sentinel nodes. All patients were treated with radiation to the whole breast. Compared with SLNB plus completion ALNB, SLNB alone resulted in similar 5-year overall survival, disease-free survival, and recurrence events. At a median follow-up of 9.3 years, the 10-year OS DFS were statistically similar between SLND alone group and the LND group. The only additional information gained from ALND is the number of nodes containing metastases. This prognostic information is unlikely to change systemic therapy decisions and is obtained at a cost of a significant increase in morbidity. The only rationale for ALND in these patients would be if the finding of additional nodal metastasis would result in changes in systemic therapy. Because current guidelines do not support differences in adjuvant systemic therapy based on the number of positive lymph nodes, except in some uncommon select subgroups, ALND does not appear to be warranted in this patient population. The Z11 trial did not include patients undergoing mastectomy, those undergoing lumpectomy without radiotherapy, those treated with partial breast irradiation, those receiving neoadjuvant therapy, and those receiving whole breast irradiation in the prone position, in which the low axilla is not treated. In most of these patients, ALND remains standard practice when SLND identifies a positive sentinel node. There are some instances where the principle of the Z11 eligibility can be applied outside of its criteria, such as in mastectomy and neoadjuvant chemotherapy. The International Breast Cancer Study Group, or IBCSG Trial 2301, is a randomized, multicenter, phase 3 clinical trial comparing axillary lymph node dissection with no further surgery for patients with sentinel node micrometastasis with a minimal tumor burden of less than 2 millimeters in 1 to 2 sentinel nodes. The primary endpoint of the trial was disease-free survival, and the secondary endpoints were overall survival and systemic disease-free survival. There was no statistically significant difference in the 5-year disease-free survival and overall survival between the two groups. The conclusion: ALND may be avoided in early breast cancer and limited SLN involvement. Because of these two randomized trials and other studies that examined the role of ALND in managing limited axillary disease in women with early stage clinically negative node breast cancer, the ASCO changed its guidelines from recommending ALND for all patients with a positive sentinel lymph node in 2005 to recommending against ALND for patients with fewer than three positive sentinel lymph nodes in 2014. Although the ACOSOG Z11 trial established that completion ALND is not necessary for patients who have only 1 to 2 positive sentinel nodes, patients who had gross extranodal extension were excluded from the trial. Thus, completion ALND is still considered the standard of care for patients with gross extranodal extension of sentinel node metastasis, regardless of the number. According to some studies, there is a greater risk of having pathologic N2 disease, increased disease recurrence, and decreased survival. However, none of these studies was prospective. Thus, most experts recommend that all patients who are found to have extranodal extension and any number of sentinel nodes should be offered completion ALMD because of the high axillary nodal disease burden associated with extranodal extension. Patients with large tumors but clinically negative axilla were excluded from the ACOSOG Z11 trial. Although SLNB can be performed in such patients, conclusions drawn from the Z11 trial cannot be applied to such patients. Thus, completion ALND is still offered as the standard of care for any patient who has a large, more than 5 centimeter tumor with any positive sentinel nodes. Sentinel lymph node biopsy performed before or after neoadjuvant systemic therapy have varying accuracy and identification rates. Factors that determine accuracy and identification rates include the timing of the procedure, method of lymphatic mapping, whether single or dual agent, the number of lymph nodes harvested, and the surgeon's expertise. There are two landmark studies on sentinel node biopsy in the neoadjuvant systemic therapy setting, the Sentinel study and the ECOSOG Z1071 or Alliance trial. The ECOSOG trial enrolled women who had clinically T0 through T4, N1 through N2, M0 breast cancer. Enrolled patients received neoadjuvant chemotherapy. After chemotherapy, patients underwent both sentinel node biopsy and ALND using both blue dye and radioisotope, for which the identification rate was 92.9% and false negative rate was 12.6%. The pre-specified endpoint of a false negative rate was less than 10%. This threshold was considered acceptable based on prior studies of SLN surgery reporting a 10 to 12 false negative rate following chemotherapy in clinically negative node 0 patients. Because of this rate was not reached, widespread use of SLNB after neoadjuvant chemotherapy in node-positive patients was not recommended. One factor identified in the ACOSOG Z1071 as contributing to a higher false negative rate was increased axillary fibrosis after neoadjuvant chemotherapy, which makes lymphatic drainage and surgical dissection more challenging. The authors concluded that changes in approach and patient selection would be necessary to support the use of SLNB as an alternative to ALND in this patient population. Further evaluation of data, however, showed that if three or more sentinel nodes were removed using both dye and tracer, the false negative rate fell to 9.1%. Some experts have accepted the use of SLNB after neoadjuvant chemotherapy when tracer and dye are used together and three or more sentinel nodes are removed. The Sentina study included breast cancer patients with clinically node-negative disease who underwent sentinel node biopsy prior to neoadjuvant chemotherapy. If the sentinel node is positive, a second sentinel node biopsy procedure or reoperative SLNB was done after neoadjuvant chemotherapy. Patients with clinically node-positive disease received neoadjuvant chemotherapy. Those who converted to clinically node-negative disease after chemotherapy underwent sentinel node biopsy with backup axillary dissection. The detection rate of sentinel node biopsy before neoadjuvant chemotherapy was 99.1%, while in patients who converted after neoadjuvant chemotherapy from clinically positive to N0, detection rate was 80.1%, with a false negative rate of 14.2%. In patients who had reoperative sentinel node biopsy after neoadjuvant chemotherapy, the detection rate was 60.8% and the false negative rate was 51.6%. Based on these studies, careful patient selection and the use of dual agent mapping technique is recommended to optimize the outcome. Sentinel node biopsy should not be performed in patients with clinically evident residual nodal disease or poor response to chemotherapy. Reoperative sentinel node biopsy is also not recommended because of the low identification rate and high false negative rates. If the status of the axilla needs to be documented prior to neoadjuvant chemotherapy, ultrasound guided fine needle aspiration of the suspicious node may be done. The American Society of Clinical Oncology does not recommend sentinel node biopsy in patients with T4 or inflammatory breast cancer who have received neoadjuvant chemotherapy, regardless of the patient's clinical response, and data are insufficient to recommend SNB in patients with T4 breast cancer whose cancer has been clinically downstaged after receiving neoadjuvant chemotherapy. SNB after neoadjuvant chemotherapy is associated with a learning curve, and success is dependent on the surgeon's expertise. This is because the axilla often has more fibrosis after chemotherapy, making identification of the lymphatics and surgical dissection more challenging. Another drawback of performing SNB after neoadjuvant chemotherapy is that the SLN removed may not be the same node previously biopsied and found to be metastatic, and this may lead to understaging and undertreatment of the patient. All of the women in the ECOSOG Z11 trial received whole breast irradiation, as did 90% of the women in the IBCSG 2301 trial. Given that part of the axilla is included in the treatment field with whole breast radiation, women who received radiation in the two trials probably experienced a therapeutic effect from radiation sterilizing any residual tumor cells in the axilla. The same benefit would some of whom underwent mastectomy. Patients were divided to those with positive sentinel nodes by SLNB and randomly assigned to receive either ALND alone or axillary radiotherapy. There were no statistically significant differences in disease-free survival and overall survival between treatment groups. Lymphedema was noted significantly more often after ALND than after axillary radiation at 1, 3, and 5 years. After 10 years, axillary recurrence remained low and comparable between ALND group and the axillary radiotherapy group. Distant metastasis-free survival and overall survival rates were similar. The Amaros trial showed axillary radiation to be acceptable alternative to ALND in patients who have positive sentinel nodes but do not meet the Z11 criteria. For those who meet the Z11 criteria, axillary radiation is likely to add morbidity without conferring any additional benefit compared with whole breast irradiation alone. Additional studies are needed before regional radiotherapy can be accepted as a standard approach for patients with axillary metastasis. Thank you very much.
Thank you very much, JT. I hope that answered a lot of questions. So, as mentioned, sentinel node biopsy is a highly multidisciplinary procedure requiring close collaborations between the surgeons and other specialists. The next two topics are very essential to its performance. Let me now call first to lecture on the role of nuclear medicine in sentinel node biopsy, Dr. Jonas Santiago.
Hi, good afternoon. Uh, can you see my slides?
Yes, Dr. Santiago, if that is your slide. Yes,
Okay,
I can see the title page.
okay, good. Just confirming. Okay, uh, well, the previous lecturers, particularly Dr. Uy, Dr. Noriega, and Dr. Ordonez, actually touched a lot already on the role of nuclear medicine. And actually, the way they tackled the topic is much better because it's from the surgeon's perspective. So, well, anyway, what I'll be lecturing will be this will be a short lecture just to give you the nuclear medicine perspective, uh, the nuclear perspective on the whole thing. Okay, so uh, sentinel node lymphoscintigraphy. This is part of radio-guided surgery, which nuclear medicine does as a service to the Department of Surgery. And in this slide, you see breast cancer is in red because, of course, this is a breast cancer meeting, but it can also be done for the other cancers mentioned, particularly melanoma, and I know it's been done for head and neck cancer, understudy testicular cancer, colon cancer, prostate cancer, and of course parathyroid surgery. Now, uh, the big hospitals in Metro Manila has been doing this actually for almost 20 years. No, but now I think all nuclear medicine departments in the Philippines, I mean, all hospitals with a nuclear medicine department, I cannot imagine if they are not offering this Sentinel Node lymphoscintigraphy, because all it takes is a camera and the supply of the radiocolloid, which is not difficult. So, but these are the pioneering hospitals as far as the uh, procedure is concerned. As far as the procedure is concerned. Okay, now as far as field health is concerned, actually, they're not, field health actually recognizes the procedure, and they actually have a code, RVS code for it. But I was informed by one of our surgeons that, because of the case rate, of course, the patients will only get the benefit of, I think, one or two RVS codes, and of course that will be the more expensive RVS codes, and so, this may not be applicable. But just so you know, it field health recognizes this procedure. Now, we've already discussed. It was already discussed earlier, the blue dye method, radioactive tracer method, and the dual method. Now, of course, since I'm in nuclear medicine, I'll be talking more about the radioactive tracer method or the radionuclide method. But I am not about to say that the using technetium sulfur colloid is the better or the more effective method, because definitely, as our earlier lecturers have mentioned, it is actually the experienced surgeon who will determine how effective the procedure is. So, but in my experience, using a sulfur colloid, and radionuclide lymphoscintigraphy has a less steep learning curve, meaning it's easier to learn. And of course, the dual method is the preferred method or standard of care if both methods are available, because then you have two modalities helping you locate the node. You are using your eyes to look for the blue dye, and then you are using your ears actually to listen to the sound of the gamma probe telling you that you are near the Sentinel node. So the problem with the radioactive tracer method is that it requires a whole department to back it up. Unlike if you're going to use the blue dye method, then I guess the only thing that you need is a supplier for the blue dye. But for the radioactive tracer method, since it is radioactive, there are a lot of things that have to be ready. The hospital has to have a nuclear medicine department, and I'm sure you realize that there are some big hospitals in Metro Manila with no nuclear medicine department. So it's not that easy. So of course, you need a gamma camera to do the imaging, and then the intraoperative gamma probe, which is used intraoperatively to help locate the Sentinel node. Now, the gamma probe, there's actually a supplier for the gamma probe who, if you don't want to buy it, you can actually just rent it, and they charge you per use. So a hospital with if the census isn't too big to justify the purchase of an intraoperative gamma probe, then you can just rent it. And the sulfur colloid that is used is widely available and can be delivered to any department with a nuclear medicine, to any hospital with a nuclear medicine department. Now, this is a slide that was already projected earlier by one of our lecturers, but just to emphasize well, I'm just going to make comments because they mentioned some nuclear medicine aspects in their slide. Like for this slide, the injection of the radioisotope is done preoperatively, and that's in order to be able to do the lymphoscintigraphy. Now, the tracer that we're using is sulfur colloid. In other countries, they may be using some other form of radioactive colloidal material, but uh, the most widely used is sulfur colloid, and that is what is available here. I mean, in our country. Now, it is not a new radiopharmaceutical. We've been using sulfur colloid for more than 20, 30 years. It was originally used to image the liver and the spleen and the bone marrow. It's technetium-99 base, so it has a half-life of 6 hours. Now, the sulfur colloid can be filtered or unfiltered, and the slide shows you the difference in the size of the filtered or unfiltered. So, what's the difference? Well, if it's filtered, then it goes through the filter, which makes the colloidal particles smaller. The implication of that is that well, you will see the nodes faster, but the problem is it may see more nodes also. Of course, if you you want to visualize just the first echelon nodes. You don't want to see the second or third echelon nodes because those will not be the sentinel nodes anymore. Now, if you use unfiltered, then the nodes may appear slower, meaning it takes more time to appear, but there's less chance of the second echelon nodes appearing. Now, the dose that we're injecting is dependent on how long is the interval between the injection or the scan and the actual OR cutting time. So that if if it's just a few hours before the surgery, then we inject a smaller amount of radioactivity, and that's for radiation protection, because even though the radiation that we're injecting is already very small, of course, we go by the as low as reasonably achievable mantra. So if we can get away with a very small amount of radiation, that is what we're going to inject. Of course, if the surgery is going to be like 12 hours after the injection, like for overnight, like let's say if we scan the patient the night before the scheduled OR, then we will have to inject a bigger dose of the radioactive colloid so that there will be enough radioactivity left in the node come OR time. Okay, so how do we inject? Well, blue dye, as you know, is injected right before cutting. Now, radiocolloid actually it's usually injected a few hours before so that there's time to do the scan, but it can actually be injected at the same time as when the blue dye is injected if the patient does not need a scan, or if the surgeon decides that no scanning is needed. Now, why will some surgeons decide on that? Well, actually, some patients will be so sensitive to pain so that they don't want to be injected, in the breast area while they're still awake. So when the patient is already asleep from the anesthesia, that's when we inject the radio tracer, and so the patient, does not feel anything at all. Of course, that means that there's going to be no scanning anymore also. Okay, so well, this is just a diagram of the different injection techniques, and the one encircled is the one that I'm using all of the time, intradermally, periareolarly, at the same quadrant as where the primary tumor is located. So it can be injected 1 to 12 hours, and the volume of the tracer that we inject is usually between 0.2 to 0.8 ml. Now, it depends on the amount of radioactivity that we're planning to inject to the patient. Of course, we're using the smallest needle so as to cause the least amount of pain. And we usually apply EMLA before the injection, even though the only pain that it relieves is the pain of the initial injection of the needle prick. But actually, when you inject, they still feel the pain. But at least there's this psychological effect that we did the most that we can to lessen the pain. And of course, note that in this picture, the hand holding, which the patient needs as we inject that radio tracer near one of the most sensitive areas of this patient. And this is how the scan looks like. On the left is with the flood, and the on the right is with the flood source. The flood source is just that the radioactivity around the patient, so that you can make out the the outline of the patient. Because if you're just going to look at the scan, then you don't, it looks like just an ink blot. But if you look at this other scan with the outline of the patient, then you know, oh, okay, so this is in the left upper, and this is the arm of the patient, this is the head of the patient, and this is the left axilla of the patient. So then you can, make heads or tails out of it. And this is a picture that was already shown earlier, and it's being shown in juxtaposition to this image, so that you can imagine, this is the injection site and this is the node. And so same thing, this is where I injected, and that's where the node appears. And this is also a slide that's already shown to you before, wherein you can see the first echelon node, the first echelon nodes, or in the second tier or second echelon nodes. And if you're going to do SPECT CT of the SPECT CT of the scan of the lymphocytogram, you can actually visualize those second echelon nodes too. Like, for example, this is the injection site, this is the first Sentinel node, and these are the second tier nodes. And the advantage of doing SPECT CT is that you could locate the node exactly where it's located, and even give you information as to how deep it is. Okay, is scanning needed? I already mentioned that certainly for some patients we don't do scanning at all. Like for those patients who we inject in the OR because they don't want to be injected while awake. And as you know, when you inject blue dye, there's no scanning involved there, and it can also be done without scanning. But the advantage of scanning is already mentioned earlier. The advantage of that is, first, well, it gives you an idea how many nodes there are to locate, the relative location of the nodes. Is there an internal mammary node, even though it may not figure in how you're going to manage the patient? And then the depth or how deep is the node if you're going to do SPECT CT. And of course, the whole point of scanning before any surgery is so that you won't be surprised when you open up the patient. And you've seen much better pictures of this, and even in video earlier. So same thing. And so this is when we're measuring the node, making sure that it is the Sentinel node, and that it counts far above the background. Okay, I'm just going to make some comments on some of the slides that were shown earlier, wherein nuclear medicine was mentioned. Now, one of the contraindications for doing a Sentinel node procedure is allergy to blue dye. Well, actually, for those cases, then you can do the radioactive sulfur colloid, because allergy to blue dye doesn't mean you will be allergic to the radioactive colloid. And actually, as far as we know, we don't know of any patient who is allergic to the radioactive colloid. The most reaction that patient complains about is, of course, the pain of the injection and some redness which may happen in the injection site. And in the earlier lecture by Dr. Ordonez, she mentioned the special circumstances. So patients who already had previous breast or axillary surgery, they can still do. We can still do the Sentinel node lymphocytography. We just inject in the same quadrant as where the primary site is located, and it doesn't matter whether the breast mass has been removed. Usually, we try to inject periareolar but lateral to the incision site, so that there's no scar tissue to impede the progress of the radiocolloid to the axillary node. And it was mentioned earlier that blue dye may not be used in a patient who is pregnant because of the potential teratogenic effect. Well, a radioactive colloid may not have any teratogenic effect, but we in nuclear medicine usually shy away from injecting any uh, patient who is pregnant or who might even be pregnant, and who might be pregnant. And the reason is because if ever something does happen, it will be hard to convince the patient and sometimes even the doctor that it was not because of the radioactivity. Now, and just to put the amount of radioactivity into perspective, uh, the amount of radiation that the patient is exposed to in a sentinel node lymphoscintigraphy is around 52 microsieverts, while the chest X-ray that the patient probably underwent as preoperative examination is 100 microsieverts. Okay, and well, if the patient has bilateral breast cancer, and if you're going to do bilateral sentinel node procedure, then we will inject both breasts, and we can certainly locate the sentinel node in each axilla, if that is what you require. Now, the sentinel node dissection can, well, usually it's done before the mastectomy, and that's actually most of my experience. But I've also assisted surgeons who do the sentinel node dissection after they have done the mastectomy. And for those cases, it may be easier to find the node, the sentinel node, because then there is no background radioactivity to confuse, the location of the sentinel node. There's less background activity. There's the injection site is no longer there because it was already removed with a mastectomy. But of course, whether you do it before or after the mastectomy, that's for you to decide. That's the surgeon's decision. And it was mentioned earlier about the some gamma probe issues. So just remember that the counts cannot be adjusted, but the alarm can be adjusted. So that the alarm has to be adjusted so that it only makes a noise or a sound when the gamma probe is over the node. You don't want the gamma probe making a sound when it's just over the background. Otherwise, you'll be confused. So you adjust the sensitivity of the alarm so that it only makes a sound when over the node, but the counts remain the same. You cannot adjust it. Of course, if the area of interest is too near the injection site, like let's say the sentinel node is too near the injection site, then yes, it may be difficult to locate the node, because then you won't know, because then the gamma probe will be detecting the radiation not just from the injection site but also the sentinel node, so you don't know which is which. For those cases, that it may sometimes it may be advisable to do the mastectomy first and then look for the sentinel node after. Okay, so some surgeons may be concerned about the amount of radioactive exposure, that they experience, when they're handling these radioactive nodes and the radioactive breast which we've injected. Well, studies have shown that the average radioactive exposure to the hands of the surgeon is around 0.04 millisieverts. And the yearly dose limit for the hand is around 500 millisieverts. So that means you have to be doing around more than 10,000 breast surgeries a year for you to exceed that dose limit for the hand. So you're safe. And so, which brings us to pathological accuracy. So the whole point of the sentinel node dissection is so that you give your pathologist only 1 to 3 nodes instead of giving him 10 to 13 nodes to examine. Now, and the nodes that you are giving the pathologist is not just one any random 1 to 3 nodes, but these are the 1 to 3 nodes that are most likely to harbor metastasis, so that he can use all his multiple sections, immunohistochemical stain, all his techniques in his armamentarium to find out if there is metastasis in that node. So that's the end of the slide. Thank you.
Thank you very much to that was a wonderful lecture from our best dressed speaker. Kala ko itutuloy mo na ang pathology, Dr. Santiago, ha?
Segue lang
Ito
yan.
po si Dr. Madrid. Okay, so sentinel node biopsy represents an important and timely advancement in accurate pathologic staging, but we surgeons would also be very much dependent on what our pathologist will tell us, especially during frozen section of the sentinel node that we've harvested. So to discuss the important process of what to do with the sentinel nodes pathology wise, I would like to call on Dr. Um, Manuel Madrid to um, continue with the conference.
Hi, good afternoon. It is my pleasure to be invited to this conference. I will be presenting how sentinel node biopsy represents an important advancement in accurate pathologic staging. For microscope study. Next, please. While a sentinel node is totally blocked, regardless whether it is for frozen section or routine evaluation, the two procedures are different in their own ways. By FS, the lab requires at least 1 day advance notice in order to prepare the cold tissue cutter or cryostat to below minus 20 degrees Celsius to freeze the embedding medium and the tissue. While via routine evaluation, the ordinary tissue cutter or microtome is functional to cut through hardened paraffin at room temperature anytime. Review of previous H&E diagnosis is helpful before or during FS, especially for special type breast cancers presenting as small lobular type cells or well differentiated glands. On routine, however, knowing the prior histology is ideal but not required, as there is no time constraint to get additional data, take more sections, make deeper sections, or be able to check the histology of the primary tumor in the lumpectomy or mastectomy specimen. When using radio-labeled tag, lab personnel are exposed to minimal radiation dose during FS, while only negligible to nil on routine, as we let the tissue stand in formalin and be grossed on or near the 72-hour limit, that is 3 days, effectively going through 10 radiation half-lives. For a busy lab such as ours, more than one cryostat machine may be required in order to maintain a reasonable turnaround time. Because if you must know, it takes about 15 minutes spent for every block of tissue that is made during FS. And this is inclusive of the cutting, the staining, and microscopic evaluation. With routine processing, in contrast, a clear-cut diagnosis takes about 3 to 5 days turnaround time. Next, please. Okay. Except for the above differences, both procedures share common steps. Pertinent clinical information is important. Examples include previous core or excision biopsy diagnosis of in situ or invasive carcinoma, or prior neoadjuvant cycles, as there are treatment effects in the lymph node brought about by chemo that might confound the pathologist, at times rendering evaluation difficult, if not impossible, in FS. Next should be the laterality of the sentinel lymph nodes. This is important in cases wherein there is bilateral mastectomy for invasive carcinoma in one breast and in situ in the other, both undergoing sentinel lymph node biopsy at the same time. Crossing the sentinel lymph node to indicate as labeled, hot meaning radio labeled, blue meaning with dye, hot and blue when labeled with both radio tracer and dye, palpable or suture tag. We report when we see or don't see lymph nodes in fibrofatty tissue. When visibly apparent, we indicate the number and sizes of the nodes. We employ hematoxylin and eosine or H&E staining of the tissue sections both in FS and on routine, although the staining schedule is abbreviated and way much faster in FS. Next, please. Here is how our frozen section area looks like. It is where we do the gross evaluation and sampling and the staining. For guidance of all pathology trainees and consultants, we post a step-by-step sentinel lymph node procedure as encircled in red that I will show you on the next slide. Notice the cutting area with the cutting board, an overlay of clean bond paper, a metal ruler, tissue forceps. The staining rack is behind the cutting board. Next, please. So here is how we process sentinel lymph nodes intraoperatively. This post is quite helpful as we have many pathologists and we have new residents and histotechnologists at least every year. Without a posted guideline, deviations from the standard operating procedure will always creep up sooner or later. So as numbered, document the size or sizes of tissue or tissues received. We bluntly dissect the node from the surrounding fat. We trim as much fat as possible. We document the number and size of lymph nodes isolated. We submit the entire lymph nodes for cutting in the following manner. If 3 millimeters or less, we submit unsectioned, and they may be combined in one block. For lymph nodes greater than 3 millimeters, we slice at 2 to 3 millimeter intervals along its long axis, and we submit all slices in a non-mirror image cutting phase. We use separate blocks for every big lymph node, and we do not combine big and small lymph nodes in one block. We also do touch imprints and scrapes from cut surfaces of nodes. These are helpful for rapid cytologic survey. And then we take or get up to 4 step sections per block. Next, please. Here is an example of a properly labeled specimen. We check for name, accession numbers, laterality, and the tissue itself. No fixative for FS. Adequate volume of neutral buffered formalin for routine. Next, please. The specimen is oftentimes surrounded with fibrofatty tissue on receipt. Next, please. Before dissection, we take measurements of the specimen as we receive it. Next, please. We measure the fibrofatty specimen. Next, please. Taking 3 dimensions in centimeters and up to the nearest point sub-centimeter. Next, please. Dissection starts with deep, even palpation for nodes. Next, please. Fatty tissue is hard to cut in cryostat, and more often than not, fat conceals the node rather than reveals it. Worse, because fat doesn't freeze or harden well, whatever node within the undissected fat will not be firm enough to cut and will have a likely chance to be lost or missed on cutting. Next, please. And so we separate as much covering fat as possible. Next, please. Fat sort of gives or gets squished on firm palpation, leaving the node, which is usually a rubbery to firm tissue, round to oval shape. Next, please. When a node or nodes become apparent by feel, we remove the surrounding fat. Next, please. Leaving the lymph node for further description. Notice that the lymph node has a sort of bluish to blue-green tinge. That is the effect of the blue node. Next, please. In this example, we were able to dissect two lymph nodes. If some remaining tough fatty tissue adheres, we let it be as we might get lucky and see some extranodal extension. Next, please. So we measure again, this time the dissected nodes. Next, please. Each node and in 3 dimensions. Next, please. We then slice the node that measures more than 3 centimeters. Next, please. Slicing the node in about 2 to 3 millimeter thickness. Next, please. Next, please. And then, and all the way to the other end of the node. Next, please. Next, please. Okay. The reason why we cut in 2 to 3 millimeter slices is to avoid missing macrometastasis, which is defined as a nodal tumor deposit measuring more than 2 millimeters. The reason why we submit or load all slices is to avoid macrometastasis in other deeper areas of the lymph node. This scheme, while designed to catch macromets, does not have a failsafe for micromets and isolated tumor cells. We catch these small mets nevertheless, but we might miss a few of them in FS. Next, please. We do touch imprints and knife blade scrapes of the cut surface of the lymph nodes so that we get a rapid cytology bird's eye view of the node while awaiting the tissue slides. Next, please. This is an H&E stain of a touch imprint, especially with macromets and more often than not in micromets. We can have a cytologic diagnosis even while the tissue is still being cut in the cryostat. Next, please. Here is the work phase of a cryostat. On the upper left is the temperature reading at minus 20 degrees centigrade. This should be turned on first thing in the morning when there is a contemplated FS for the day. Next, please. We submit all the lymph node sections. One cut surface of a lymph node section faces the blade. The other section must have the opposite cut surface facing the blade, the non-mirror surface, so we can evaluate other levels of the node. Cut surfaces of big and small nodes differ in terms of depth of sectioning. The entire cut face of a big node may present on early cuts or trims, while that of small nodes may need deeper trimmings. Next, please. Here is how thin sections of frozen tissue are taken. The picture on the right shows a round thin section that has been sliced and is being picked up on a glass slide. In our practice over time, we found that taking at least 4 sections per block prevent false negatives. Next, please. Here is the schedule of a rapid H&E. This process takes 5 minutes compared to routine H&E, which takes up to 1.5 hours of staining. Next, please. The procedure is about the same in routine section, except that tissue processing takes 12 hours and that the embedding medium is paraffin wax. Next, please. Using the microtome in routine, the histotechnologist makes a tissue ribbon and places that ribbon on a glass slide to stain and be visualized under the microscope. Next slide. Here is a sentinel node with macrometastasis on FS. It measures 2 millimeters or more. Next, please. And here is one with micrometastasis. It measures less than 2 millimeters. Next, please. Here is an isolated tumor cell cluster that is missed on FS. Next slide. Here is how we report the sentinel lymph node. We report the absence of the lymph node if there are only fatty tissues submitted. When present, the number of node or nodes isolated and examined, positive or negative for nodal mets. If positive, the number of nodes, and if with extranodal extension. For post-neoadjuvant treatment, we indicate positive or negative for metastasis, and we indicate the presence of treatment effect. Next slide. This is our FS data a few years back. We haven't collated our recent stats. As you can see, we have great positive predictive value and negative predictive value. We have good sensitivity and specificity. Our false negative rate or FNR is about 9%, but that is because our prevalence of positive SLN is only about 6%, which is about 21 positives. And to be able to get an FNR of at least 5%, we need 20 true positives and just one false negative. We just don't have enough true positives to be able to improve our FNR. In addition, we do sentinel lymph node also for DCIS, one for every 6 invasive carcinoma. Having stated such, the two cases that we missed were both micromets. So next, please. We seldom request for immunohistochemical stains, and only when we have a hard time classifying atypical cells on H&E. Aside from isolated tumor cells and macromets of invasive lobular cells that we agonize and may miss, there are much red herrings or potentially false positives that we need to exclude, like benign epithelial inclusions, big reactive histiocytes, prominent blood vessel endothelial cells, among others. Next, please. Like in FS, we dissect, prepare, and submit the entire sentinel lymph node on routine section. Next, please. So in closing, the takeaways. Any node labeled sentinel is and must be blocked entirely, whether in FS or routine. Sentinel lymph node by FS is great as long as your lab has the capability in terms of cryostat and manpower, and as long as the FS limitations are understood by all parties, including the patient. Pathologists will try to avoid false positives all the time, but we'll have to make do with missing rare true positives. A couple of good practices. When more than one sentinel lymph node is submitted for FS, we try to divide the turnaround time in chunks by reporting to the OR every after one lymph node, or reporting ASAP a positive node, even while processing the other sentinel nodes. And our frequent flyer breast surgeons, they always remind the lab how to process our SLN by writing on their request forms that we need to make 2 to 3 millimeter cuts. That's all I have. Thanks for your kind attention.
Thank you very much, Manny. We will see if there are members of our audience na kasing kulit ko, kasing kulit namin. Thank you. So, for our last lecture, Sentinel lymph node poses a series of unique challenges for the institution or individual surgeons wishing to set up or start this practice. Alvin, can you flash the next topic? Yeah. Okay. So to wrap up, connect, and practically guide us how to apply all previous lectures to send us all on our way to start doing sentinel node biopsy, I would like to call on Dr. Aldine Basa.
Okay, thank you, Marcel. So I will be discussing the validation study. And how to validate yourself for the sentinel node biopsy technique. So as we all know, sentinel node biopsy requires a close collaboration between the surgeon, the pathologist, and the nuclear medicine physician, as you have seen with our previous lectures. And we found that surgeon experience was found to have a significant effect on the sentinel node detection rate. Team experience, case volume, and adherence to established protocols make all the difference. And the learning curve is associated with the technique. So before you embark on sentinel node biopsy, there are a few requirements. Obviously, we need the operating room, a pathology lab capable of performing frozen section and routine histopathologic examination. And when you start this procedure, both the surgeon and pathologist should undergo validation. And in institutions with a nuclear medicine department and a nuclear medicine specialist with training in lymphoscintigraphy, the dual technique is recommended. In institutions without a nuclear medicine department, then blue dye alone can be used. So the recommended number of cases to ensure acceptable success rates is 20. So we recommend that you do 20 cases in combination with a backup axillary dissection. And usually the recommendation is that the first 5 cases be supervised by a mentor. So if you have a breast surgeon in your institution who does this routinely, your breast surgeon can assist you and supervise you for the first 5 cases, but you must complete 20 cases in combination with an axillary dissection to validate yourself. And it is important to have the following goals. You have to have a false negative rate of less than 5% and an identification rate of at least 95%. So it's very important that you document these 20 cases that you're going to do. So we've decided to narrow down the inclusion criteria for patients who would for surgeons who would like to undergo validation, just because it would be better to be more conservative since you're learning the procedure. So for the patients included for validation, obviously female patients with an established diagnosis of invasive or microinvasive carcinoma by core needle biopsy or vacuum-assisted breast biopsy or excision biopsy. We have limited this to just T1 and T2 tumors, and the patient must have a clinically negative or imaging negative axilla. And you can do this for patients undergoing partial or total mastectomy. So you can do this for breast conserving or for patients undergoing a mastectomy. So the exclusion criteria for patients for your validation are as follows. So there are quite a few patients that we've excluded. So obviously T3 and T4 tumors, as was discussed earlier, are excluded. Inflammatory breast cancers, you should not do a sentinel node on that, obviously. Metastatic breast cancers, patients with clinically suspicious palpable axillary nodes, abnormal lymph nodes and imaging, biopsy proven axillary lymph node metastasis, patients with supraclavicular lymph nodes or previous axillary surgery, or history of radiation to the axilla. If this patient has had a previous excision biopsy at the upper outer quadrant, we would encourage you to exclude these patients. You know that it can still be done, but since you're validating, it's better not to include these type of patients in your validation. Previous non-oncologic breast surgery. So these are patients who've undergone a breast reduction, augmentation, to exclude them from this kind of procedure. Patients who have undergone neoadjuvant chemotherapy for bilateral breast cancer, patients with a BMI of more than 35, so your obese patients, or patients with abnormal creatinine or with renal disease, obviously pregnant and breastfeeding women, and those who would not consent for an axillary dissection. Remember, you will have to explain to all these 20 patients that they will have a backup axillary dissection. And those with an allergy to the blue dye. So for the pre-op preparation, obviously the informed consent is very important. You have to include the details of the procedure. If this patient will have dual technique, you need to explain that a procedure will happen earlier before surgery at nuclear medicine, and a radioisotope will be injected into their breast. You have to explain the injection of the blue dye, possible allergic reaction to the blue dye, and also discoloration of the urine. Post-op, discoloration of the breast, if you're conserving the breast. And most importantly, that you will be performing a standard axillary lymph node dissection after the sentinel lymph node biopsy, because this is for the purpose of validation. Obviously, medical clearance when indicated, and anesthesia evaluation. So for the nuclear medicine part, as Dr. Santiago mentioned earlier, we have the nuclear medicine department with a gamma camera, gamma probe, technetium sulfur colloid, which is what we use in the Philippines, a trained nuclear medicine specialist in lymphoscintigraphy. And usually we do the lymphoscintigraphy 4 to 6 hours before surgery. If you like to operate 7 o'clock in the morning, then you can do this procedure the night before. And as Dr. Santiago said, the dose of the radioisotope is increased if it's given the night before. The nuclear medicine personnel and gamma probe should be in the operating room at the time of surgery, and the radioactive counts of the sentinel nodes and background are documented. So every time you get the ex vivo counts, they have to write it down. And also, once you've finished your sentinel node biopsy, do a background count as well. Now, for the surgical procedure, obviously these patients are under general anesthesia. For those injecting dye, we can inject methylene blue, the medical grade methylene blue, or the patent blue dye, or with the radiocolloid. For the methylene blue, you could use 2 to 5 millimeters of 1% methylene blue or the patent blue. Usually we do subareolar injection, as mentioned earlier. You may do peritumoral, most commonly is the subareolar injection. Remember that methylene blue, if injected very superficially, is very notorious for necrosis of the skin. So if your injection for patent blue is very superficial, like it's intradermal, try and go a little bit deeper for methylene blue. Massage the breast for 5 minutes. So with the blue dye, the massage, we have to massage for 5 minutes. There was a question earlier about ICG. When you inject ICG, there's no massage that happens. You just wait for the ICG to travel to the sentinel node. But with blue dye, you have to massage. Inform the anesthesiologist of the possible oxygen desaturation due to the blue dye. And remember, the sentinel node biopsy usually precedes your total or partial mastectomy. And when you do the counts for those doing dual technique, the count has to be over a 10-second period. So you check the activity over the injection site. Obviously, it's very high. You do an ex vivo count of each node. And you also insert the probe into the axillary cavity and check the background count. And note this as well. So like we said earlier, what are the criteria to develop, to identify a sentinel node? These are nodes that are hot, meaning they have a loud feedback when the gamma probe is pointed towards them. The nodes that are blue, nodes that are hot and blue, those nodes that are at the end of a blue lymphatic, or the firm node on palpation. So a maximum of 4 nodes is usually regarded as the sentinel nodes. And if you are unable to identify any sentinel node, which has happened, this is regarded as a failure of the sentinel node identification, and an axillary dissection must be done. So all identified sentinel nodes will be harvested and labeled in accordance with their order of identification. So the first node that you've identified and excised, that will be sentinel lymph node number 1. Then the second one will be number 2, and so on. So ideally, we should get at least 1 to 3 sentinel nodes with a median of 2, maximum of 4. Most pathologists get angry if you get more than 4. So a maximum of 4. Proper labeling and documentation of all the specimens should be done. Now, for the pathologic evaluation, the pathologist should also be validating themselves at the same time as the surgeons are validating. So all sentinel nodes must undergo frozen section or interop evaluation, and the final histopathologic evaluation of the sentinel node should be done using the H&E staining. And the pathologist can compare and see whether they're getting accurate frozen section findings and what their false negative rates are. Frozen section will be used in examining sentinel nodes without completion axillary dissection later on. So it is necessary for the pathology department to validate the accuracy of their frozen section during the time the surgeon validation is being done. So this is very important. You know, a lot of pathologists say, you know, we've been doing frozen section for the longest time, so you don't really need to validate the pathologist. But you know, it's very devastating when you have a false negative and you have to explain to the patient that they need to go back to the OR. Because in many instances, they don't want to go back to the OR. So you're left with a big problem. So it's very important that both pathologist and surgeon validate. And the pathologist must be able to differentiate and state whether the sentinel node has micrometastasis, macrometastasis, or isolated tumor cells. So the two most important rates that we need to reach for validation is your identification rate and your false negative rate. So the recommendation is that you should have an identification rate of at least 95%. So you compute this by getting the total number of successful mapping or successfully identified sentinel nodes over the total number of sentinel node biopsy cases done. So that's pretty simple. And you get the percentage of that. If you are 95% or higher, then that's very good. And then you need to compute your false negative rate. So you look at the number of cases of false negative sentinel lymph nodes. So these are the nodes that were negative on frozen section and then positive on your final, over the patients that are true positive plus the false negative. So the true positives are those that were positive and frozen and positive and final, plus the false negative. So that's your denominator. Oops. And if your false negative rate is less than 5%, then this has been a successful validation and you can start doing sentinel node biopsy on your own. But you have to, and I cannot stress more emphatically that you have to finish the 20 cases of validation. So proper documentation of the validation procedure is required. And the surgeon should keep a detailed record of the procedures he or she has performed. How will you know your accuracy if you're not detailing and you're not recording the times that it took you to identify the node, your accuracy rate and everything? So you're only going to do this for 20 patients, so it should be very detailed. Now, a learning curve really exists and the technique is mastered at different rates. Obviously, if you have many cases and you're able to do this, one after the other, it really helps. Versus you do one case, let's say this month, and then the next one will be after 6 months, then it will take longer and it's actually harder to master because of the time interval in between cases. So the surgeon should continue validation until the standards are achieved. So you should persist until you finish the 20 cases. If you're able to do the 20 cases faster because you have more cases, even better. But the reality is that that may not be so. But it is still important that you persist and finish your validation. Thank you.
Okay, thank you very much, Aldine. So let me now, I think that's the end of, that's the last lecture. So I would like to call on our panelists, Dr. Noriega, Dr. Madrid, Dr. Santiago, and Dr. Abasa. Okay. I would also like to call Dr. Acosta to help us with the questions coming from the audience.
Hi, Dr. Good afternoon.
So, congratulations, JT. Ganda ng lecture, ah. So, can you lang summarize kung when can you omit completion axillary lymph node dissection in patients with positive sentinel nodes for those undergoing BCS and for those undergoing mastectomy?
Well, for one thing, ma'am, again, the patient the patient's profile is that the patient should be Z11 eligible. So this has been said since the beginning of our seminar. T1, T2 lesions, clinically node negative patients undergoing breast conserving surgery. And if you have one or two nodes that are positive, then the patient can opt to have just radiation. Okay. For patients undergoing mastectomy, it's a bit tricky because, as we know,
The more
statistically,
common procedure here in the Philippines.
that is correct. So statistically speaking, I think most patients who are diagnosed with breast cancer, some sort of mastectomy, nipple sparing, or regular mastectomy. Um, Now, ideally, the patient should be advised to undergo node dissection because that is the current practice. Um, uh, but for patients who choose not to undergo this radiation treatment, it is still possible because some trials show that radiation is comparable to radiation post-op radiation. I'm
You
sorry,
meant
sorry.
for patients
Post-op,
who refused axillary dissection.
yes. So
Mhm.
post-op radiation is equivalent to that of axillary lymph node dissection.
So pag positive
Ah,
yung nodes, they refuse axillary dissection, they need to undergo radiation for
that is correct.
patients undergoing mastectomy.
That is correct. And for the for patients undergoing,
JT, hello?
yes po,
Hello?
yes ma'am,
Sorry. Oo.
yeah. For
Ah, sorry. Nagloloko. Okay. So for patients with positive lymph nodes who refused axillary node dissection, you will advise them to have RT. Hindi pwedeng i-omit yung RT.
ideally, yes ma'am,
Yes.
ideally, yeah.
Okay. So, since you made a very good case of promoting RT as a substitute for axillary dissection in node positive patients, will you recommend omitting sentinel node biopsy altogether and just sending the patient for RT?
Well, there are certain trials right now, under trials that are undergoing.
Hello?
I think it's the ma'am.
JT, I think mahina yung signal.
Oo. Okay. Can you hear me now?
Yes ma'am, yes ma'am.
So, will you recommend not omitting sentinel node biopsy and just, referring the patient for axillary radiation?
No, no, ma'am. So the principles of this what we discussed now will still apply to regular patients.
Okay.
So that there are there's a I think the sound trial is already done and will be wrapped up by the end of 2021. And as I think Ella mentioned earlier, that we are veering towards this era wherein sentinel node biopsy may be altogether scrapped for patients who are clinically negative, clinically node negative, imaging negative, and who have T1 tumors. But we have to wait for the results later this year.
Okay. So, may tanong ako kay Dr. Santiago. You mentioned something about doing sentinel node biopsy after mastectomy. But can you clarify when do you do injection if you will do the sentinel node after mastectomy?
Uh, well, actually, I've assisted the surgeons who asked me to come in after they've done the
Mm-mm.
mastectomy so that I can help them locate the sentinel node. So the patient is injected or the scan is done a few hours before the OR, just like any ordinary patient, except that the dissection just happens after the mastectomy.
Aldine, I think naputo na naman. Can you make a comment on that, Aldine?
Well, I think it can be still that way. The problem only is if they injected blue dye already, and you wait till the mastectomy is done first, then the blue dye is going to go to the second echelon. I mean, if they already injected the blue dye. If they haven't, then it could be okay. I mean, the only reason why we do the sentinel node biopsy first, apart from the fact that we don't want it to go, the blue dye or the radioisotope to go to the second echelon of nodes, is also because we have to wait for pathology to read it. So it's better to do the sentinel node first, and then while pathology is reading, we're doing the mastectomy. So we're not just sitting around, getting so impatient and bored. We're doing the mastectomy. But I guess it can be done. But what do the surgeon that you're talking about, did they cut the mastectomy specimen out already and then do the sentinel node?
Uh, no, well, actually, when they ask me to come in, I usually notice that breast, the breast is still there, but it's just hanging by a small slipper maybe. So that there's only one incision site, so that they'll be dissecting the node, but uh, the mastectomy specimen is already like way out of the field already.
So do you find that they get more nodes that are maingay when you use the gamma probe, since they're doing it after the mastectomy?
Actually, no.
No?
No, not necessarily. And it's actually easier to look for the node, because then any noise that that makes uh, uh, on the site, that's the node, and it's not the injection site that's just causing some background noise.
Okay, but these cases that you've seen, did they inject blue dye as well?
No, they did not.
No. So I guess it could be it's acceptable. Yeah.
Actually, that's the first time I've heard of that. Doing a mastectomy before a sentinel biopsy. Dr. Santiago, I have a question. In the U.S. and Europe, the surgeons they do the injection intraoperatively. They have a license. They have a certification that allows them to inject with tracer. I wonder if we can have that here in the Philippines, and if it's possible for surgeons to have that certification.
Well, I don't see why you will not be allowed to handle radioactive substances, as long as you take the course that the regulatory body requires anybody who wants to handle radioactive substances. And cardiologists, radiation oncologists, endocrinologists take that course. It's offered by the Philippine Nuclear Research Institute, so that anybody who takes the course, it is like a 1 month course. Then you will be allowed to handle radioactive substances. Of course, in subject to the approval of the nuclear medicine department, where you will be handling.
Thank you, Doc. Thank you.
Doc, we have questions from our for our attendees. This is Ella po pala. To Dr. Santiago, sir, there's a question regarding the pain caused by injecting radiocolloid material. Is there any effect of mixing lidocaine with the radiocolloid material to lessen the pain for our patient?
Well, there won't be any effect on the scan itself or on the sensitivity, but if you're going to think about it, the pain of injecting the lidocaine will be the same as the pain of injecting the sulfur colloid, because the sulfur colloid itself does not cause pain. It's the volume of the material, of the liquid that you are injecting, intradermally near the areola, that causes the pain, because you're causing a wheal, in that area. Now, if you're going to add lidocaine, then that just increases the volume of what you're going to inject. So then that will just increase the pain. Remember, even if lidocaine is an anesthetic, if you inject it intradermally, it will hurt.
Noted po, Doc. That's a very good point po. There's another question, Doc, regarding naman radiocolloid access.
outside of Metro Manila or where you have nuclear medicine facility, how much would be the cost for our patients?
Well, the radioactive colloid will be supplied in any nuclear medicine department in any hospital in the country, because hospitals, before they set up a nuclear medicine department, they always make sure that there will be a supplier, and the suppliers, it's their business, so they make sure that when a nuclear medicine department is being built, they're already there at the start to supply you. Now, of course, if it will be outside of Metro Manila, of course, it's going to be more expensive. The reason is because the supplier is based in Metro Manila, and I don't think they've already. There are only two suppliers actually in the country, and I don't think they've thought it economically feasible yet to have branches outside of Metro Manila. So what they do is they just ship it from Manila to Davao or to Cebu or wherever you have a nuclear medicine department.
Doc, we have a patient in Davao City who's interested in having a dual agent, uh, SLNB. Can we give like a quotation for our patients? How much do they need to prepare just for the radio, just for the materials, the instruments, and the agent?
Okay. Well, for Davao, I know that the Davao doctors has a nuclear medicine department, and I guess you should be able to ask them how much would be the landed cost, because it will always have to be cost to the department and to the hospital, and of course the hospital will have to add whatever they need to add to that cost. But uh, uh, given that the cost of the radio colloid will vary from around per dose around 2 to I think 5 or 7,000, depending on who supplies you and where it's coming from, and if the hospital has a deal with the supplier. Because, like for example, in the hospital I work at, in order for them to supply everything that we need, then we have some kind of a contract wherein the each dose is actually discounted.
Thank you, Doc. Last question, Doc, regarding the lymphoscintigram. So in other countries outside of the Philippines, we noticed that lymphoscintigram is actually no longer done. But is this really still essential in our local setting?
Well, for one thing, what the scan does is, well, it gives you an idea of how many nodes there are that can be detected. And I think it was mentioned in an earlier lecture about neoadjuvant therapy making it more difficult to locate the sentinel nodes. Now, if you don't have a scan, and then, well, at least the scan will give you an idea how difficult will be locating the nodes. Because if the nodes are very faint on the scan, it's going to be a difficult search. Whereas if it's very intense, then it will be relatively easy to find. I guess that's one of the uses of having a scan before. Of course, it gives you an idea how many nodes there are to locate. But yeah, but definitely, if you it can be forgone, because I've done it, and I gave the examples earlier for those patients where we didn't do a scan. But yeah, but there are advantages to having the scan done. And in the hospital where I work at, the difference in cost is actually very minimal, because the cost of the scan itself is just a few hundred pesos. So and so most of our surgeons just decide to just have it done anyway.
It's 6 o'clock. Okay. I have a question here for Dr. Madrid. Manny, you mentioned something about you doing imprint cytology on your 2 to 3 millimeter cuts of Sentinel node. So
Yes,
based
doctor.
on your finding on the imprint cytology, let's just say you saw some cancer cells there. Will you advise us to just base our next step during surgery on the result of the imprint cytology? What is your evidence regarding the reliability of that procedure?
Thanks for the question, doctor. Right now, no, I don't advise it yet. But within the laboratory itself, when we see tumor cell clusters in FNA, in the touch imprints, we expect to see a positive node When we do not find that node to be positive, we get still more deeper sections until
So,
we document it.
so this is actually a question that concerns time, no? Like
Opo.
if we're waiting for the frozen section, nag-positive na sa imprint, safe not to proceed with ALND and not wait for the frozen?
Okay, the short answer actually is yes, pero I think we need to gather more data so that we will be confident in telling you that yes, we can. But my experience is in those instances when I did get positive touch prints, the lymph node turned out to be positive as well.
So it's
So
it's
that's good.
it's actually very, very important for the surgeon and the pathologist to be talking to each other regularly,
That's right. That's right.
especially in your expectations in putting up the guidelines in the institution, right?
Yes, Doctor.
Okay,
So if
so
you have when we have numbers, we will tell you, Doctor.
okay, so we would like to emphasize this that okay, this is for Aldine. I think can you give tips on how to approach and explain to the patient that they will be part of a validation study, knowing that they are sentinel lymph node only eligible but needs to have one setting completion axillary dissection because the surgeon is for validation.
Well, one of the that's a big challenge. But when our institution was validating, what we did was we would explain to the patient that the institution itself doesn't do this yet, and because we're in the process of validating, we need to do both. And if they want to have their surgery in the institution, then this is what we offer. If they're really adamant on having just sentinel node biopsy, then you have no choice but to tell them that they need to go elsewhere. Now, if in your institution you have a breast surgeon who does sentinel node biopsy and is already validated, then you'll have no choice but to refer to that surgeon. But I think it's easier to convince them if you, as an institution, you're validating, because it kind of gives them, that there's no option but this. You know.
Okay. In relation to that, Aldine, so you said that if your institution has a surgeon who is validated and that mentoring is allowed in the completion of your validation, right? Is it possible to just you know ask the one who is ask the validated surgeon to do the surgery with you? Parang nandun siya. Pwede na ba yon?
No, you would have to refer that patient to the validated surgeon, and then that patient will be done by the validated surgeon. You can only have a surgeon assist you once you have finished your 20 cases with backup axillary dissection.
Okay. So there is a question here. Can you repeat the let's ask Manny this definition of the false negative rate?
The false negative rate is as per what Dr. Aldin posted a while ago. It's the number of false negatives over total true positives plus false negative times 100. That's the false negative rate.
Right. So the axillary lymph node dissection is really needed for the denominator of that false negative rate.
Yes,
For
I
the
suppose so.
computation, right?
Yes, Dr.
Yes. Okay. So, importante talaga yon. So, Aldine, can you do validation using one method? And if you get validated with that method, can you shift techniques. Like for example, if you get validated with the dual method and then you decided afterwards that you only want to do use methylene blue, is that is that